this morning, so for anyone I haven't said good morning to, good morning. And we will go live in about 30 seconds. So good morning. I believe it's gone 10 o'clock and I think we are now live. Yeah, I've had that signal, so that's great news. So good morning, everyone. It's Monday, the 5th of July, 2021. This is the Health and Care Overview and Scrutiny Committee for Staffordshire, and I am your chair, Councillor Jeremy Pert. Before we start the meeting itself, I just wanted to make two comments, please. The first one is the obvious one, that 73 years ago today, the NHS was created back in 1948, a service that was free at the point of use for all citizens, founded on the principles that services should be comprehensive, universal and free at the point of delivery. A health service based on clinical need, not ability to pay. And those principles are still there today. So much has changed in that time, not least life expectancy. For someone born in 1948, their life expectancy at the time was 66 if you were a man, and 70 for women, as against closer to 79 and 81 today. So I'm sure you would like to join with me in celebrating all that has been achieved in those 73 years, and as such, I would like to recommend that at 11 o'clock, we join with NHS colleagues nationally from across the country to hold a 2-minute silence across this chamber. Are we in favour of doing that? Thank you for your support with that. Secondly, I would like to welcome the chair of East Staffordshire's Community Regeneration, Environment and Health and Wellbeing Overview and Scrutiny Committee, Councillor Colin Wildman. He has been recently appointed, so first of all, congratulations to him on his recent appointment. And second of all, congratulations on joining this committee. I would also like just to note our thanks to Councillor Adam Clark for his service. So let's start with apologies.
Yes, Chair. Apologies from Councillors Jack Abrahams, Martin Buttery, Paul Northcott and Thomas Jay.
Thank you, Debs. So declarations of interest.
Yes, Chairman. I'd like to declare that I've got an interest. I'm partner governor on the MPFT from the County Council.
Thank you, Councillor Edgeler. Any other declarations of interest? I'm looking around the room and there is no one signalling, so let's move on to the minutes of the meeting from Monday the 7th of June. Firstly, are they a true and accurate record? Thank you. I've got Keith Lunder proposing and Anne Edgeler seconding. Are we in agreement? Good, no dissent, so that's good news, thank you. So before I go on to matters arising, not on the agenda, can I just comment that we agreed to set up a resource library last time around. That isn't yet up and running, but we've had a number of discussions to find the right medium to allow our district colleagues to be able to access the county council system. We could set something up tomorrow if it was just for the county councillors, but I'm very clear that this is a collaborative committee with important partnerships with our district and borough colleagues, and it's important that those members from the districts and boroughs are able to access the resource library. So once we've got past that hurdle, we will come back to you. I'm hoping it'll be in the next month. Are there any other matters arising from the minutes not on the agenda for discussion today? I have no dissent, so let's move swiftly on. So that is the quickest we've done those for a long time, so thank you for your help this morning. Let's move on to item number 4, restoration and recovery. I believe we have a glittering array of people who want to contribute to this and to lead us in the discussions. So I think we've got Marcus Warnes from the CCG, Helen Ashley from UH&M, Simon Evans, Duncan Bedford, Lisa Agel, Jane Munton-Davies, and If I've missed anyone out, can I apologise? So, who would like to take us away? Marcus,
If I
over
could
to
just
you.
start off, Joe, if that's okay. Yeah. Given the nature of our health and care system, the reason there are so many people here today is just to reflect the fact that we have a lot of providers, some of which cross more than one system. UHDB, for instance, Duncan's here, sort of sits within the Derbyshire system, but 20% of our patients go to Burton for their care. Likewise, a lot of patients in the south go to Royal Wolverhampton, which is in the Black Country system, and Simon is here for that. We sometimes get very much focused on UH&M, which is our main local provider, and don't probably spend enough time on the 50% of our patients that go outside of Staffordshire for their care. So thank you to colleagues for joining me. We've also got some significant issues around mental health and community service as well as general practice. So whilst we'll limit the number of people that are presenting, I think having colleagues here to pick up any questions you've got, thank you for their time, and I think that'll be helpful. Before Helen starts, Helen's going to run through the slides, the restoration recovery slides. I just wanted to say a few words, if it's okay, Chair, on the local situation by way of context, because obviously we've got the 19th of July, Freedom Day on the horizon. Some conflicting messages coming out nationally from scientists and from politicians around what the current situation is and whether it's safe to do that or not. So I thought before we get into the restoration recovery piece, some people have asked me, well, is it right to be looking at restoring and recovering services when case rates are still on the increase and people are very concerned around the Delta variant? We are in a very different position now than we were in January, and certainly in the first wave. I think from the NHS perspective, given today is the NHS's birthday, a lot of the restrictions were very much around protecting the NHS. And that was very welcome and necessary, certainly in the first and second waves. But we are in a very different position now. One of the items that you're covering later on is the vaccination programme, which nationally and locally has been a roaring success and has put us in a very, very different position to the one we were previously. I think in January we had something like 33,000 people in beds across the country. Today we've got 1,900. People in beds with COVID. We had about 100,000 new cases a day in January. We've about 24,000 now. We had deaths in the hundreds every day. It was about 15 over the weekend. I think in January you had something like, if you caught COVID, about a 1 in 60 chance of dying. That's now less than 1 in 1,000. And that's largely down to the fact we have a really effective vaccination programme, and I think 85% of people now have got antibodies, which is through being vaccinated or having caught and recovered from COVID. So it is the right time to be looking at restoration and recovery. I think as provider colleagues will tell us, it's not people with COVID now that are the problem, it's all the other stuff that we've been dealing with over the last 14 months or so. And whilst, as you'll hear from Helen, emergency departments are under huge pressure, again, it's not with people with COVID, it's other stuff. Last week at the Strategic Coordination Group and the Restoration Coordination Group, Recovery Coordination Group, there's a lot of discussion around it. It feels like we're betwixt and between at the moment. The next round of significant easing of restrictions are coming along. The NHS is still concerned around what that might mean because case rates are rising. And you'll hear more about the impact of that on R&R from colleagues in a moment. But it does feel the right time to start looking ahead and thinking about we're living very much with COVID and with the pandemic. It's not going to go away. It will be with us for a good time now. And we do need to start giving confidence to people that they can come back, start using the services, coming back to have their cancer diagnosed, etc., and anything else that ails them. So I just wanted to say that at the beginning, really, because I think sort of watching the media, some colleagues might be thinking, well, why are you asking, why are you standing services up when we're still battling a pandemic? It does feel like, as I said, we're in a very different position. You may want to ask some questions about that later on, and you'll be hearing about the vaccination programme later on as well. So I think probably pause at that point and ask Helen to take us through the slides.
Thank you, Marcus. I don't know if we've got anybody who's going to share the slides, or whether or not you want me to share them.
I think Tanisha or someone. Tanisha's doing that.
Perfect. Perfect. Thank you. So, and thank you, Chair. So, as Marcus said, I'm just going to run through a number of slides. I'm Director of Strategy for UHM, but I do also take the lead on behalf of the ICS for Planned Care. We have got colleagues on here from the 2 other acute provider trusts and community and mental health. So even though I will cover those within the presentation, there'll be an opportunity to ask them more detailed questions at the end. So if we just go on to the first slide, and I expect just by way of overview, as an NHS now, we've been working to a set of planning guidance issued in March 2020 around how we stand back up some of our services that have been stood down. This is our second instance of restoration and recovery within the NHS. As you're probably aware, we attempted to restore services during the early to late summer last year, and were highly successful in doing so. And then obviously, as we got the sort of second and third wave, we had to stand back down some of those services. It obviously, having stood them up last summer, the process of standing them up this year, I think, has been far more straightforward, because it's become systems and processes that we're used to. But as Marcus has already said, what has challenged us is the demand for urgent and emergency care that we've seen at our front door. So that has put a challenge on us as organisations. As I know you're aware, we've continued throughout the whole period to deliver essential services, life-threatening and urgent surgery, and obviously we've continued to provide those services through our A&E departments. We are, though, currently still constrained by capacity within critical care and what we would call our green non-COVID beds to be able to stand back up that activity. And I think one of the biggest challenges that we face beyond our physical estate is our workforce resilience and our staff well-being, and all very conscious, as I'm sure you are, of your staff, that actually we need to continue to support those staff who have been through so much in this last 18 years, and not just assume that they are willing and able to start to recover those services, and indeed go above and beyond in order to make sure that we can recover those services in a timely fashion. Marcus is right, the numbers, I think, within all of our hospital settings have significantly reduced from where they were. During this last week, we have started, certainly at UHM, started to see a small rise in those numbers, but it is nothing like what it was last year. But to be assured, as NHS organisations, we will all continue to monitor the number of COVID patients come in, and one of our focus for the coming months will be what do we think winter demand, both for COVID and flu and those usual winter pressures, might look like, and what impact might that have on our services. So if we just go on to the next slide, and just to say that actually, as we're focusing on restoration and recovery now, we're doing it on all aspects of our services. So in terms of health and wellbeing of our workforce, how we recover elective and diagnostic services, the focus on cancer care, urgent care. Primary care is a really important component of our ongoing ability to be able to provide services, as is the need to make sure that as we're doing so, we are not furthering health inequalities. And I think there's a recognition that through the COVID period of the last 18 months, though not deliberately, some of the ways in which we have stood up our services or indeed constrained them has broadened health inequalities. So certainly for a health service going forward now, we need to be very sighted on that, have a better understanding of it, and also make sure that before we make any further decisions about how we deliver services, we have health inequalities in mind. And then lastly, but not least, mental health services. And we know that colleagues in mental health continue to provide support over the last 18 months to patients and our staff, and we know that the demand for their services will grow over the coming months as people return to whatever we think the new normal is. So the three biggest risks to our recovery are workforce resilience, our ability to be able to continue to restore our activity, and also widening health inequalities. So if we just go on to the next slide, and I'll just talk in a little bit more detail about 3 of those. So we know that, as I've already said, our staff have been through significant amount in this last 18 months. We have come together as a group of healthcare providers to put in place health and wellbeing hubs to be able to support all of our staff, either those who have been off having suffered from COVID and are now suffering from long COVID, or those that are basically struggling with the workload and some of the exposure that they've had to very challenging conditions in this last year. So as I say, I think workforce burnout is our biggest risk. What we're seeing currently, and I'm sure this is no different to other sectors, staff absence is now starting to grow again. A number of our staff are now being required to either isolate because young family members have tested positive, or they're required to support childcare arrangements because their children have been asked to isolate as a result of positive COVID cases within the education environment, and that is impacting upon our services. We're hopeful that perhaps a change in regulation or indeed the coming of the summer holidays will positively impact, but that is a real risk to us as we stand. And during certainly the course of last week, our staff sickness as a result of COVID, and I think across all organisations, has continued to rise, and it wasn't something that we'd seen in the previous few months. I've talked already about elective care. We are currently, as NHS providers, trying to focus on what we would call priority 2 cases. So our priority ones are those that need immediate life-saving intervention. Priority 2 are those in that next category down in terms of their urgency in requiring treatment, but we are also starting to focus on long waiters. And we know because of COVID, we've asked people to wait a significant amount of time, and so we are now going back to also focus, as well as those that are clinically urgent, on those patients who have waited at least over a year for their surgery. And though cancer care has continued during the course of the pandemic, and cancer patients have always been prioritised for their surgery and their first outpatient, we have, as I think we all predicted, started to see an increase in referrals. Certainly, I think all providers are struggling with demand for breast care, and there are new models now being put in place across communities to be able to more appropriately receive those triages. And actually, if patients can be seen by community services, then they should. And the best example of that is a breast pain clinic, which is being stood up across a number of health systems now. And it's just a better way of being able to stratify demand and to make sure those ladies, and indeed some gentlemen, who are most likely to have a cancer diagnosis, can still be seen in a timely way. So if we can just go on to the next slide, please. And the next 3 slides, and I won't linger on these, are basically a snapshot from each of the 3 provider organisations as to where they are in terms of restoring and recovering elective and day case activity. And for each of the trusts, what we've sought to do is to display where we are against the NHS set trajectories. So we've been asked to look to restore our activity levels in comparison to against a baseline of 1920 activity, and that would suggest that by April we were required to have restored our activity to 70% of 1920 levels, and then up to September 85%. And so if we just go through the next 2 slides, because actually as it stands, each of the 3 provider organisations are achieving those standards. So that's very positive in terms of where we find ourselves now. Some, certainly from a UH&M perspective, we'd hope to be doing more at this point in time, but ongoing social distancing requirements have curtailed that that ability. But certainly I think all three provider organisations anticipate being able to continue to achieve those trajectories for the remainder of the year. So if we can just go on again past the UHDB to the Royal Wolverhampton, as I say, all three organisations restoring their activity levels in line with trajectories. So if we can just go on to the next one as well, and then again, if that's okay. I've already touched on cancer demand, and again, for each of the three trusts, we are all seeing varying types of demand for those services, and some specialties now starting to struggle more than others. And I think in the main, those specialties that are starting to struggle with increased referrals are those probably that were struggling pre-pandemic. So if I speak on behalf of UH&M, we were struggling with urology before, we were struggling with gastroenterology, and we are struggling again now. All three trusts will currently be seeing increased demand for skin referrals, and that's about the time of year. We do a lot of campaigns as an NHS in terms of making people aware of potential skin cancers. So this time of year we would always see a spike in demand for those specialties. So again, if we just go through now to urgent care, if that's okay, and I'm sure each of the provider organisations will say will take questions. So during COVID, we did look to make some temporary changes to our urgent care footprint, and that broadly impacted around minor injuries units in Leek and Cannock, and saw patients diverted to other facilities. And there's been some real positives come out of the COVID experience. So for the Royal Stoke site, where we diverted our minor injuries to the Haywood, that's been a really positive experience, and it's meant that at Royal Stoke, actually we've been able to focus on the other cohorts of patients that did need to present. But clearly, as an NHS now, we need to look at where we are in respect of those that are still temporarily closed, and what it is that we're going to do to stand back up those services, either in that locality or at an alternative. We have all, in this last couple of weeks, seen huge levels of demand. No particular reason, no one particular confounding factor that I think we can attribute to that, because we know that primary care continues to see significant patients. So I think we are just seeing a level of pent-up demand that for whatever reason we didn't experience during COVID, but it is a real challenge to us to continue to deliver. So as I say, well, primary care continues both in terms of being able to offer primary care facilities and consultations to patients. They are obviously also continuing to focus on the vaccination programme, and I won't talk any more about that, because I know that you've got a presentation on that coming up. So if we just want to go on to the next slide, and this is just to be able to demonstrate, certainly for UH&M, where we are in respect of urgent care attendances at the front door. It is impacting upon 4-hour performance, and it is impacting upon patient experience, but we are all doing everything that we can to be able to make sure that those patients who are sickest and require our services are treated in a timely way. So if we can just go on to the next slide, please. So I think this is the final slide, and as I say, I've already talked about health inequalities. The way in which services were delivered during COVID at their very best didn't positively impact upon health inequalities. And certainly when we look at the way in which we've delivered some of our remote care, so virtual consultations have not made them as accessible as they could be to some of those more challenged communities. So that's certainly something that we need to think about going forward. And as NHS organisations now, we are far more alert and looking to make sure that we have the evidence and the data in front of us to the impact that it's having on inequalities. And then last but not least, mental health. As I say, mental health organisations have played a huge role in supporting acute trusts during the pandemic and supporting the delivery of care. But we know that in their own right, they have a growing role now supporting the wider population in terms of some of those challenges that people are either now facing or undoubtedly will face into the future after what has been such a challenging 18 months. So I'm hoping that that was the last slide. As soon as it's not moving on, I'll conclude that it is. So thank you very much. I'll stop there now, Chair, if that's okay. And either myself or colleagues will be very happy to answer any questions. Thank you.
Thank you. Keith. Can I ask you, just wait. Can I ask a question, please, Helen? Could you send that slide deck to Debs now, so that we can send it round committee members, just so they can go through the slides that they weren't able to read on the screen, please? Then that may inform their questions. Is that something you could do for me? Or
Yes, of course. Tanisha, are you able to do that? Because I think you've got the most up-to-date version of it.
Thank you. It proves we're still learning with this technology and trying to perfect it. I certainly understand what you were saying, because I struggled to read them, and you know, I'm very close to them. I think we've done that. Let's as soon as Debs has got them, we'll send them around committee, please. So I've seen Phil Hewitt.
Thank you, Chair. And you're going to have to forgive me, Chair, for being a little bit parochial, which I don't normally do. But the MRU unit at Cannock Chase, at Cannock, was mentioned in that presentation. It's now been closed for quite a number of months, and certainly there seems to be no indication at this stage that it is that it's opening, even though at a scrutiny meeting in Cannock Chase 3 months ago, the indication would be around 3 months. If you live in Cannock Chase, we have a long way to go for any kind of emergency care. It's either Wolverhampton or Stafford or Stoke. The MRU unit is really vital to us, even though it would be unfair of me to ask for a date as to when it would be opening again. I don't think it would be unfair of me to ask for what has got to line up for it to be open. Where do we need to be for the MRU unit to reopen? And I accept that you may not be able to answer that today. But there's a lot of concern in Cannock Chase that we have no emergency cover at all. And we sort of accepted that during COVID, not quite accepting it now, Chair. Thank you very much.
Thank you, Phil. We have a team of specialist professionals who can answer that, I'm sure. Simon, is that one for you?
Yes, certainly. I can have first attempt at this. It's as you're aware, we closed Cannock MRU, and you're quite right. During COVID, it was purely for staffing reasons. We weren't physically able to maintain all services operating at the same time. As we progress now, we are looking to see what kind of service provision we can provide, and with that, we are reviewing all services and how they are restored moving forward. So I'm anticipating that a service is provided as we move forward. The question is what that will look like, and that's what we will need to work with in terms of the local population, along with commissioners, to understand what specifically needs to reopen for Cannock and how we can best achieve that. So it is not a direct answer, and I'm not trying to be obstructive there. I'm trying to give an honest answer in terms of the process we have to go through, because just like every other service that we are restoring, they all look different as we come back to what normality looks like. So this will be no different to how we restore other services. We will have to go through that same exercise.
Thank you. Before Phil comes back, because I'm sure he will want to come back, I thought I understood that there was a 3-month timeline that it was going to be open. There was a distinct date, and that's, I understand, passed. So why was that date given in the first place, and how was the time used in the intervening period? Because it feels like that date doesn't exist in reality.
So the date which came from the chief executive was a view to say that there was an ambition to see if it was possible, rather than a definite that we would definitely be open by that date. And clearly things, this is a rapidly evolving situation, and lots of conversations have taken place with commissioners and also other providers in terms of how we can try and get a service open for the people of Cannock.
Phil?
Thank you, Chair, and thank you for the answer. I'm sorry, it gives me no comfort. And as a date was given, or an indication of around about 3 months, that date's gone now, and we're talking about a service rather than the service, and we're wondering what we're going to get in Cannock. And it's up to me to represent the people of Cannock, and quite rightly. And so far, we find the whole thing quite disappointing, because what we've not gained is an indication as to what you need to do. You know, we're looking at it rather than actually what we'd really like to see is it open. And excuse me my bluntness, I'm rarely this blunt, but I genuinely think that we should be moving faster and quicker on this. Also, you know, if we're concerned about an A&Es in Stafford and A&Es in Wolverhampton, and there's no doubt these small MIU units sort of remove the pressure from those, remove the pressure from primary care. There's a wider importance about them, and I think we should sort of be looking faster than we are to get it open. But thank you, Chair, and thank you for the answer.
Just on what you said, I'm aware that Cannock Chase District Council have got this on their radar, and they're scrutinising the reopening of the MIU. Simon, is there anything that you could offer to Cannock Chase's overview and scrutiny committee on this, so that there is a more defined timeline and step of processes that you're going to get through to be able to get to the answers that Councillor Hewitt's asking for?
So what I can't do is commit to a timeline, because at this stage we are definitely still negotiating around what that service could look like. And whilst we are still attempting to recover services across the whole of our organisation, that means that we do need to look differently at what service provision looks like. So we're having... it would be unwise of me to tell you exactly those kind of conversations today, purely and simply because we haven't yet concluded those. What I can commit to, though, is making sure that I will commit to attending the Cannock Chase Council, District Council, to talk about those and provide an update whenever that next meeting is.
Thank you for that, Simon. We'll obviously give you those dates, and I appreciate what you've said, because I think it's really important to take members of the public with us, particularly when we talk about a long backlog in services, because I note that we're only looking to get back to 75 and 85% of previous demand, which doesn't address the actual latent backlog from last year. So in reality, you know, I think it is important that Cannock do feel satisfied on this. Charlotte, can I bring you in? Thank you, Simon.
First, just a comment. Leek MIU is open. Limited hours, admittedly, but we wouldn't let any stone be left unturned to make sure that did open. So it is now open, I'm glad to say. But I wanted to ask a couple of questions. One about appointments at GP practices. When you talk about, I said earlier that the Leek MIU is open, and you need to campaign to make sure it's open, because we certainly didn't allow it not to be opened, even though it's limited hours. But I'm concerned about appointments at GP services. When you talk about appointments, do you mean face-to-face appointments? Because you talk about GP services being offering appointments 8 o'clock in the morning to 6:30 at night. I had the necessity to be in a GP surgery. Now, sadly, they couldn't find any way of proceeding with my particular case, i.e. removing stitches online. I'm sure if they found a way of doing it online, they would have done. But what I did as I was sitting in the reception, what I did hear was constant, yes, your appointment will be on the phone with the doctor, and there were sort of in half-hour slots going through the day. Now, you talk a lot about health inequalities, but it seems to me that if you are giving people appointments on the phone, you're automatically increasing health inequalities because of the ability of people to, one, express themselves on the phone, perhaps if they have a hearing or other auditory problem, and also their ability to explain their particular situation, which may be more difficult if you have a disability. And so my concern is, when you talk about appointments, are you talking about face-to-face? Because I have to say that I had a real battle to get my appointment at the appropriate time. I was told that the nurse was working from home. Well, not really very helpful, really, unless I was going to go to her home. And I stuck my ground and finally got my appointment when it needed to be given to me. But it worries me that, again, looking at health inequalities, there are people who tend to defer to doctors and health professionals who would say, oh, that's fine, yes, I won't bother, you know, and so on. And so it worries me that we're not moving away from telephone or Zoom appointments as opposed to face-to-face. If you could let me know what you mean by appointments and whether they are actually offering face-to-face. Certainly in my local surgery, it's very rarely happening. And the other thing, which I know the chairman's aware of, is visiting times to the Hayward Hospital. Because I had someone who not a constituent contacting me about that issue, and I understand that patients are only allowed now 2 visits a week. And obviously, if someone has had a stroke and is having rehab at the Hayward, some people, I believe, are now refusing to move from the acute ward to the Hayward for rehab because of the lack of visiting times. So if you could perhaps answer those 2 questions. Thank you.
Lynn, I've noticed you're with us now, so Lynn, good morning. Lynn, can we take the first question as part of the next agenda, i.e. you know what the question is, can we answer that when we get onto the next agenda item, because it relates directly to GP access, I think. Can we just pick up the Hayward question, please, albeit I do have some answers on that, but I don't think it's for me to give those answers.
Yeah, so I'm happy to take that question, Chair. And yeah, you will be aware that you yourself have raised issues about this. So the Hayward should be having visitors every day. They are in line with national visiting guidance, so it is restricted to 1 visitor and by arrangement only. So I'm very happy to take up any individual issues around visiting, because that should be in place. It shouldn't be any different. And I know we've had a number of issues raised about that. And clarified that more recently.
But hold on, just twice a week?
No, it shouldn't be twice a week. No, they can go every day. So if it's an individual case you want to let me know about, I'm very happy to pick that up.
And if we're talking to the same individual, then maybe I've already got that one covered.
Yes, yeah. If you could let me know, I'm very happy to pick that up. But it's not twice a week, it's every day.
Thank you for that confirmation, Lisa. I think it's really important. I think Councillor Atkins makes a really good point here, because it's also about the patient's mental well-being as well. And, you know, the sooner we can get them out of hospital, back home, the better it is. So thank you for that. Keith Flander.
Thank you, Chair, and good morning. I'm glad to hear that we've got some ideas about future proofing the services in relation to future outbreaks and surges with the COVID-19 and any other future pandemics. Woe forbid that we haven't learned from this and we can't protect those services that we need to do. I'm referring to things like cancer care, etc. And it's good to hear about the community services that you're intending to put back on again. Obviously, at the moment, the timetables are things that I think we're all concerned about, and it's something that I think as you come back to the committee in future, that you could maybe try and fill in a few more dates so that we can get some more ideas out there for the general public and ourselves to be a little bit less fearful of. My questions are related to staffing and admin. I'm concerned about the fact that you're reopening some of these areas and you may be struggling with staff who are now extremely tired and everything else, and we're going to do a 2-minute silence very shortly to say thank you to them all. But how are we getting on with recruiting and doing other things as normal, getting back to some normal activities? That's what this agenda item's about. Also about collaboration with partners. I'm concerned about the fact that partners might be moving at different speeds as we go out and during the restoration periods. I don't know whether any of you can have any comments in relation to that. And are we going to measure the success of restoration through the idea of declining or reducing appointments that are going into A&E? Because at the moment A&E has absorbed an awful lot of the pressures that would normally be taken under primary care and other services. And people are going there, and I'll come on to that later on when I was referred with my doctor's surgery and my daughter recently at the next item. But I'm just wondering, is that going to be a measurement of the idea that the restoration is going well and that the recovery is going well, is the reduction of pressure on A&E departments? Thank you.
Who wants to pick that up?
I'm happy to start if that's okay, and then I'll look for my other colleagues to come in. I think the first thing I would say, just in terms of recruitment, all of those things that you'd expect us to do, we have continued to do. So I think we were probably all slightly challenged by some of our overseas recruitment plans that we had, that they were put on hold a few months ago for reasons we all absolutely understand around our qualified nursing staff. But I'm pleased to be able to say that those plans are now progressing, and I know a number of our recruits are now in the country and are doing their induction programmes. We've never stopped looking to recruit to those services in terms of those workforce. So obviously, as we come out of the pandemic, we will have more time to focus on doing that and to be able to put some additional effort into that. But we've never stopped doing that during the course of the pandemic. Just the point about going at different speeds. I can make a comment from more specialist services, and I don't know whether Simon and Duncan want to pick up the more generalist, but certainly when we're talking about specialised services, and you'll know that Royal Stoke offers a number of major cardiac procedures. We are working very much as a network, so that actually if some trusts do have less capacity than others, or are suffering from a small surge, say in COVID, as we do expect will continue to happen over the coming months, then we're working together to make sure that actually certain populations aren't disadvantaged. And we did put in place during the first wave a number of, we call them hubs, whereby referrals were managed on a more centralised basis for them, those specialist care, to make sure and to avoid the situation that's just been described, so that some patients don't wait longer in certain parts of the region than others. So certainly those arrangements are in place. We can do that on a broader basis across Staffordshire, subject to patients wanting to choose to go elsewhere. And certainly we're all working with our independent sector facilities to make sure that we make the best use of those. But I don't know whether Simon or Duncan's got anything to add to those points.
Can I just, excuse me, go back to the first point as well, particularly around our staff, and as you mentioned, it's one of our top 3 priorities. So critical is to make sure as we continue, particularly as we go into head into the winter period, that we look after our staff. Fortunately, some have had a bit of a downtime, particularly our critical care staff that felt the real pressure, and some of our theatre staff. Theatres remains the biggest pressure for us, particularly as we go into the recovery, and so making sure we get the balance right for those staff when we're going to ask a lot more of them in the forthcoming year is critical. But we've also got a range of other aspects which look after our staff, We've got companies that they can dial in 24/7, and we've got various networks we've set up with our BAME colleagues, our Filipino network within UHDB. And of course, we've done a range of environmental changes also to look after our staff and make it easier for them to get some relaxation time in the midst of shift. So a lot going on for our staff. In terms of collaboration with partners, we are working particularly with the private sector as well to try and get some additionality to make sure that we can make faster inroads in terms of the backlog. But I think also we are reaching out more than we ever had before, because I think we've been forced in that direction with partners from other trusts. Helen's quite right, she talks about it at a sort of tertiary level, specialty level, but we're also working with partners on all areas, including ENT, for example, orthopedics, to see how together across various trusts we can accelerate the recovery faster. Thank you, Chair.
Yeah, and I suppose I can just really endorse those points, really. I think the staff health and well-being is a point that we should never really underestimate in terms of the importance that the how staff went over and above for the last 18 months effectively has been quite remarkable. And the constant communication and the constant reinforcement we have to give to our staff in terms of making sure that they realise that we are there for them, we will support them on this, and we've put lots of supportive mechanisms in place. Part of this is the ongoing communication, making sure that they realise we have an open dialogue with them to try and respond to some of the concerns. Certainly earliest on, the biggest concern was always PPE, and it's being able to respond to that. And then more latterly, some of the things like, for example, Duncan's just described around just accommodating some sort of things. So we have a number of marquees, for example, around the organisation where staff can try and get some breakout areas away from their roles as well. Coming to the second point in terms of how we measure what recovery looks like. I think A&E will always be used as a proxy measure for heat in the system anyway. It always has done in healthcare. But the kind of measures that we described today in terms of elective recovery and outpatients and making sure that we can, it's tackling the patients based on clinical urgency is how we need to, certainly as part of restoration and recovery, we need to focus on that to make sure that those patients that need care the most feel and are prioritised in what we are doing. And that is how we are structuring that. Of course, A&E will always be one of the proxy measures because that's where you feel the heat in the system first of all, and that's how people present also into the organisations. So again, organisationally, it's I'm making the same real points to what Duncan and Helen said. The network arrangement, so working collaboratively with other providers to see how we can support one another is one of the key things that all organisations are looking at this moment in time.
Thank you. Keith, do you want to come back?
No, just say thank you very much for those answers. Quite a lot of detail there. Obviously, we can continue some of these conversations as time goes on, but thank you very much, and thank you for the answers.
Thank you. Can I just ask a couple of points on this, because I think Keith raises a really important point, or a couple of really important points. I liked the quality of the report. What I didn't see from the report was sort of, a range of numbers and things like that. And it made it very difficult to put a context to the discussion today, in fairness. And I would appreciate some additional numbers that go with this report, so that we have a better grounding and understanding. So, for example, I don't really understand what the level of people waiting longer than 62 days is, because I think it will have gone significantly up. I don't think there can be any other alternative than that, given what we've been through. I don't have an understanding of staff vacancies, and again, that will be another useful metric, not to hold you accountable for, but just to really provide insight and understanding to this committee. And I think Keith referenced some further dates in terms of the restoration and recovery, and I do think maybe more detail in an action plan, which I'm sure you've got the action plan, but we haven't seen that. And I think that would have been quite useful for us to not necessarily hold you to task on, because I don't think that is the role today. It is more wanting to understand and support, bearing in mind we know what you've been through over the last 18 months. So maybe you could supply those elements for committee. Is that acceptable, Helen?
Yeah, absolutely. I mean, you're right. We have all got that information, and we haven't put that in the pack today, but I'm sure we can collate that and get it sent through from each of the 3 provider organisations.
Thank you. And it will also help inform when we suggest that you come back to see us, because I don't want to keep calling you in every month, because frankly, you know, whilst this committee is really important for Staffordshire's residents and for the work that you do, you've obviously got other things that you need to be doing as well at the same stage, not least restoration and recovery. Can I bring in David Latham, please?
Thank you, Chair. The subject is mental health in a teenager. 2 of us in the room have been trying to help a mother with a boy who's got enormous problems, and we're getting nowhere. This is Lichfield. Is there anyone that we can talk to that can guide us as councillors to help a family where they are getting nowhere, because everyone, it seems, in the health or the mental health services is saying nothing to do with us? And that isn't a cynical comment. Is there any point of contact for us that you could give us?
I'm sure Lisa wants to come in. Before she does, I just would like to make you aware that we have diarised some mental health discussions for, I think, the September meeting, really an awareness one, and I'm sure we'll cover the pathways in there. But let me bring in Lisa.
Yeah, thank you very much, Chair. David, I'm very happy to pick up the issue if you want to contact me directly and have a look at the case that you're referring to, you and your colleague.
Yes, sorry, can't see your name. Lisa?
A gal.
I will provide the details for you.
Yeah,
thank you.
Great. I'll pick that up directly and come back to you.
Thank you, Lisa. And David, possibly as you go through the pathway, maybe you could just make notes on that, just so that you can share that when we get to the discussion in committee in a couple of months' time. Jill Hood.
Thank you, Chairman. My question is probably aimed at Lisa. I understand mental health services are so stretched, so extremely stretched. And within your body of professionals, within the NHS, all staff, you have almost a huge family, and your people possibly suffering with PTSD, nowhere to go. They can mentor each other, they can help each other. But in my division, every day I'm meeting residents who have nowhere to go, have no one to talk to. I've managed to date over a period of 7 months to help 4 residents, but I know that there are many, many more who aren't going to see me in the high street and say, hey Jill, can you help me with this? And it really worries me. Doctors seem, and this isn't a criticism, I know it's a necessity, they're stalling for time, doctors seem quite happy to be doling out antidepressants, whereas there's nowhere for them to refer these people, because your services are so overburdened, so overstretched. I will say that the 4 people who I helped, and not obviously in a professional capacity, just as a counsellor signposting, they have been incredibly lucky with the services that they have found. But it really, really worries me that post-pandemic, there is going to be such a large wave of people really, really needing the mental health services that they just aren't going to be there. I particularly worry for young people who just have nowhere to go. And I was wondering, Lisa, what actually is in place? Are we going to increase services, increase staff? If you could just give me some guidance, I'd be very grateful. Thank you.
Before I hand over, Lisa, just bear in mind we're at 7 minutes to 11. And we'll call a break at 11. Thank you.
Yeah. Thank you, Chair, and thank you, Jill, for raising the issues, which are incredibly important issues, you know, and are very real issues. It's probably worth saying, and I think Chair did say we've got some separate sessions coming up around mental health. There are two significant transformation programmes in place at the moment that commenced in April of this year, which are both around mental health and around enhancing and expanding the offer of community mental health services, particularly both for adults and older people, but also for under 18s as well. So there is a significant amount of transformation to be done, but also I'm pleased to say new money with the ability for us to be able to recruit an additional workforce, not just from a health perspective, but also real working together with the voluntary community sector, but also our partners in local authorities. So a really significant amount of work going on. I'm very happy to talk in detail, Jill, about that with you if you want to pick up a conversation offline, so I can talk through what some of those developments are for both adults and younger people.
Yes, thank you, Lisa. I am particularly interested in alcohol abuse, which seems to be on the increase during this pandemic. So most certainly I will contact you. Thank you.
Great, thanks.
And obviously alcohol, drug and alcohol fits within the County Council's remit as well. And maybe Richard might join our Mental Health Day and just help pick up some of those other allied issues. Richard, do you have any thoughts? I knew I shouldn't have asked that question. Okay, so do we have any other questions for... Please, Janice.
Thank you very much. A couple of separate questions, in particular looking at the urgent care and, as I understand it, the walk-in cases. Is that something that is actually easing A&E? Are they cases which are appropriate to go to walk-in and certainly taking off some of the demand off GP services? And the separate question, listening to part of the recovery, looking at evening, weekend service offering, and again looking at that staff resilience that's been mentioned and how we're going to ensure that that staff burnout isn't compounded by the fact that we are trying to extend services. And lastly, going on from that, is just the nuance of the statement about offering mental health support to staff in particular, and if there is a take-up in that, not so much just the offer, but actually the engagement of those different facilities that are being made available to the staff in particular. Thank you. I'm also conscious of time, so I'll keep it at that. Thank you.
Who wants to pick those up?
So I'll pick up the last point first, and then I'll just touch on A&E, and then perhaps if colleagues again want to come. I think I would say that the uptake on all of that support throughout the pandemic has been huge, but there's been a range of interventions. So certainly our colleagues from Combined Healthcare have supported our staff in critical care right throughout the pandemic. They have been there, whenever those staff wanted a conversation, either on an individual or a collective basis. So I think it's been about the different phases of the pandemic and what people have needed at different times. But I know from some of the more recent developments, we've certainly found that some of the group sessions, some of those conversations that have taken place for staff with long COVID have helped staff get back into the workplace. We can probably, Chair, look to find some numbers in respect of the uptake on those services. So I don't think that will be a problem at all. And then just very quickly in respect of urgent care, I think it's very difficult to say that one patient shouldn't be accessing a service in any part of our A&E facilities. And we know certainly in the north of the county that the Haywood Hospital is as busy as the Royal Stoke site, as busy as the county hospital. And I think we're just seeing, people who have stored up issues aren't able to access other parts of the system because of the total demand, and therefore are going to those services that they perceive to be as accessible as they can be. And unfortunately, A&E will always be that, won't it? Because it's actually open access, and people know that if they present, they will eventually get treated. But actually, for those patients who aren't as sick as they are, suffering from some incredibly long waits at the front door.
Can I just echo what Helen said as well, just very briefly, because The numbers have increased in terms of walk-ins, but just to say very briefly that what we have found is they are appropriate self-attenders, and quite a number of them have gone on to be admitted. So it shows the severity, and I think it's like Helen says, I think it's sort of goes back to a degree of pent-up demand, which they've kept away, and now it's a situation whereby probably they can't get in, or it becomes an urgent case that they need to come in straight away, and they're bypassing their GP.
Thank you, Duncan. And that seems to be an appropriate time just to take a break for a couple of minutes, because I think we're right on 11 o'clock. So we will just break for 2 minutes and just celebrate in your birthday, the NHS, but equally be thankful for the work that you've done not only in the last 18 months, but over the last 73 years. Thank you. Can I, Janice, I'll bring you back in a minute if I can. Can I just echo some of the things that Helen and Simon and Duncan have just said in terms of staff and support and communications? I actually think you underplay some of the brilliant things that you've done in the last 18 months trying to keep the ship on the road. You don't keep ships on the road, but you know what I mean, the show on the road. Actually, I think there's some fantastic examples, and if we had time, we should probably dig through them and celebrate some of those things, because certainly from what I've heard anecdotally and firsthand from some of the people on this call and many others, you've done a brilliant job supporting your staff, because in the end, we wouldn't be where we are without staff actually supporting people and getting us through this. So maybe as part of the lessons learned, we can collate some more of those examples, because I think actually there is that positive side that we should come back through. Janice, do you want to come back?
Yeah, many thanks. I am reassured by the level of engagement as far as the interventions that are being put in place, and also that it is a complementary facility, and that the walk-in side is helping. And I think that rightly so, whilst there is that pent-up demand, that all of those are made available, but are used correctly, that they are used. And sometimes that's down to the communications, but it is reassuring to hear that those are becoming effective. Thank you.
Anne.
Can I just say, Chairman, would it be an idea that we send a letter from this committee thanking the NHS and that for all the work that they've done? I know we don't live in a perfect world, but I think they're doing a really good job at the moment and doing the best in the, the situation we're in. So would it be an idea, would people agree to send them a letter from this committee?
What do we think? Richard?
Chairman, I'd certainly second that. And if I heard correctly this morning, I understand Her Majesty has given them the George Cross, which is the only third organisation that has been awarded to. So I think we ought to express our congratulations on that award as well.
Is that the view of everyone in this room? I seem to have a unanimous position on that, so thank you, Councillor Edge. Let's take that forward and we will do that. Have we got any further questions for this item? I've got one on that basis. So what really concerns me is the specialisms that have been very difficult to continue. I mean, ear, nose and throat is probably the best example, I would guess. I have no real view in terms of how you're going to recover the more extended backlogs, because, you know, we'll talk about backlogs being an average, but actually the reality is there are certain specialisms that are haven't been able to operate during operate effectively during COVID. Would it be advisable if we got an action plan on those very clear specialisms where the backlogs are that severe because of the inability to operate effectively? And could someone just sort of talk a bit about that? Because in the end, it's not that, you know, on average everything has been elongated by a couple of weeks. It's those ones where they've gone significantly further than that.
So again, I'm happy to kick up. I mean, I think we're broadly, as providers, taking a three-pronged approach to this. So the first would be to make sure that actually all of our capacity is now open and staffed wherever possible. And that hasn't always been the case during the last 18 months. So the first would be making sure that our existing workforce is deployed appropriately, our existing facilities are deployed. For specialties like ENT, there's a national recognition that this is a challenge, and so we are engaging with our regional and national colleagues to look at what best practice looks like, because we're not always as efficient and productive as we can be when we deliver some of these specialties. So that's certainly one part of the programme of recovery. The second, I think we've already mentioned in terms of the independent sector, there will be a number of procedures that are done within some of those specialties that can be done in the independent sector. They don't need to be done on a busy acute site that has access to the full range of facilities. So we are all, wherever possible, looking to maximise the use of the independent sector. And then the third is because we recognise the challenges that our own workforce have had in the last 18 months. We're probably all working with organisations who work outside of the NHS but bring staffing resource within it. So, for example, I'm sure none of us here operate our theatres 7 days a week, 14 hours a day, because we don't have the staffing resource to do it. But there are a number of organisations who are able to bring in additional staffing resource, so that actually when we haven't got the staff to be able to run, say, theatre lists within our theatre complex, they are able to bring in additional staff, sometimes to work alongside ours, to deliver that extra capacity, because we absolutely want to be assured that for our own physical capacity we're making the best use of it, and that of the independent sector. So we're trying to tackle this from all different directions, recognising the constraints that we have, but I'm sure that we can provide details down to specialty level for all three organisations, how long patients are currently waiting and what we think that trajectory will look like over the coming months.
Thank you.
Duncan, did you want to, sorry?
Thank you. That only just sort of raises one question in my mind. In terms of communication with patients, what does that look like?
So I think that's something, and again, happy for Duncan and Simon to come in. I think that's something that we've all struggled with, and we're very conscious that actually patients who have been on a waiting list for some time now, their default, if they're not able to access ourselves, is to contact primary care colleagues, and that isn't appropriate, because it just adds to their existing workload. So I think that certainly from a Royal Stoke and UH&M perspective, we are looking to put communication out to patients who are on our waiting list. The first is to say that they might be contacted in order to transfer their care to the independent sector, and to encourage them to be open-minded on that, because we have seen a number of patients who've said no, they're quite happy to wait and continue to get their care within the NHS facilities. And the second is also to make sure that actually patients do still want their treatment and their surgery, and that isn't always the case. Quite often patients' conditions change, or they decide for whatever reason that they no longer want surgery. So absolutely making sure that the people that we have on our list are those patients that want surgery and are still wishing to proceed with that is really important. So certainly that's an approach that UHM is taking. I don't know, Duncan, Simon, whether there's anything from your organisation that's different.
Yeah, not necessarily different to that, no, but it's the I think we're approaching it in exactly the same way you are, but it's I think the validation exercise is very, very helpful in this, because and I know a comment was made earlier around some long waiting patients. What we are finding is that there's some patients who are electing to wait slightly longer, and some of that is through fear of COVID, some of that is their personal circumstance. But the validation exercise is definitely something that needs to be done with patients, and it's actually quite a fruitful process, not least of which because you get a better understanding of the clinical position, but it also starts that communication process with the patients themselves and understands what's happened to them whilst on that waiting list.
Just finally, to add from myself, we do recognise that communication with the patients is critical, particularly when we've got long waits, and we have set up a specific department which is built on some of our existing admin teams to try and improve on that. I'm not saying it's perfect in any way, shape or form, because sometimes we just can't give the answers about when precisely you are going to come in, given the long waits we've got. But we do recognise it, and we are actively trying to communicate more efficiently, or make it easier for the patients to communicate with ourselves.
Thank you for that comprehensive answer. So on that basis, I'm not getting any further indications from here. So what I'd like to do is thank NHS colleagues for your input today. Thank you also for the promise of some additional data. Philip, you just indicated.
Yeah.
Go on.
Thanks, Chairman. It's not about the paper itself. It was more about the desire to write to the NHS, which is a vague, who do you write to in the NHS? And I'm sat here thinking, I think it would be better for us as individuals and representatives on a scrutiny committee. It can be a bit awkward if at the next meeting we're criticising somebody that we've congratulated at the last meeting. I think what we ought to be doing is writing to the councils, and that we should be congratulating the NHS on the award of the George Cross and thank them for all the work that they've done as an organisation and individually during the pandemic. I think it could be a bit difficult for a scrutiny committee to be writing. That's just a comment from me.
Can I suggest that we pick that up afterwards? You and I can have that conversation, and then we'll sort of send a note around the committee and give the committee the options. I mean, we have written before, particularly on vaccinations, but I do take your point. But I like to be even-handed. You give with one and take with the other.
I think they've done a good job, Chairman. I think it's just a matter of doing it in the correct way, and I think that we should talk about it at the council meeting later this month.
I think that's a sensible suggestion, yes, because it may be that the leader wants to write on behalf of everyone. So let me just bring this item to a close. NHS colleagues, thank you for your input today. Really appreciate the time you've put to this. Also appreciate the offer of some additional information just to back up the discussion today. Obviously, we recognise it's a difficult position that we're all in, and we would, I'm sure, like to invite you back at the appropriate point going forwards. Not quite sure when that is. We'll take that under advice, but otherwise, thank you for a very informative presentation and lively discussion this morning. Obviously, if a number of you want to stay, you're welcome to do so. Equally, if you want to depart, then that is equally fine. That doesn't extend to, I don't think. So we're going to move on to item number 5, which is general practice access. Simon, goodbye. Thank you. Lynn, can I hand over to you, or is Marcus going to start? Who's going to start with us?
No, hand over to Lynn. Over to you, Lynn. I'll stay.
Thanks, Marcus. Thank you, Marcus. Hello, everybody. My name's Lynn Miller. I'm the Director of Primary Care and Medicines for the Staffordshire CCGs. I'm joined today by my Deputy, Sarah Jeffrey, who's the Deputy Director of Primary Care, who will be picking up some of the action plan that we've got around access and the road to recovery. So we'll do a bit of a double act. Just in terms of Councillor Atkins' questions, I think we'll probably cover some of that as part of the presentation. So if I don't answer your question, Councillor Atkins, please do let me know and I can answer it afterwards. So I think it's fair to say there is an issue around access in general practice at the moment. 92% of all contacts go through general practice in the NHS. So you can see we're dealing with a huge volume of patients on a daily basis, and any increase in that as equates to thousands of additional patients coming through the system a week. And obviously, as the gatekeeper to the NHS, there's a systemic problem when it's difficult to get in to see your GP. So if I could just move on to the slides, please, Tanisha. What we'll do is just run through the current position and where we find ourselves now, some of the reasons behind that, and then we'll get on to what is the most important part of the presentation about what we're going to be doing about it, because I think what I don't want to do is list all of the excuses why it's so difficult. We really need to be more proactive. We need to be working with colleagues in the council and councillors beyond about how we can engage with patients and communicate some of the issues you're facing and also come up with some solutions. So just in terms of the context, during the pandemic, practices were open between 8 and 6:30, Monday to Friday. And they've also got extended hours outside of these times. During the last 12 months, all 146 practices in Staffordshire remained open. We had a couple of afternoons in a number of practices where we've had to close for cleaning. And we had a couple of tricky situations where we've had to parachute all the practices in to cover practices that have got difficulty with staffing due to COVID. But throughout the pandemic, all of our practices remained open throughout, and that was really important. There was a national standard operating procedure that practices were informed to follow. So this was around total triage of all calls coming into the practice to apply clinical criteria of whether they needed clinically a face-to-face appointment or whether it could be managed remotely. And during the early days of the pandemic, my teams deployed something like 1,000 monitors, another 1,000 headsets. We built 700 laptops with the IT team and got these distributed to allow the majority of practices to offer remote working. In fact, all practices were able to do that. Pre-pandemic, in terms of face-to-face appointments, we were probably about 80-20 in terms of face-to-face versus teleconsults. At the peak of the pandemic, it was more like 20-80 in terms of the majority being delivered by telephone consultations. Where are we now? Last month, we were about 45% were face-to-face. This month, we are seeing practices open up more, but still around 50-55% are face-to-face. And actually, some of the feedback we're getting from patients is that this is a really convenient way. This is a way of contacting your GP that people want to continue. Clearly, the ratio face-to-face and teleconsults needs to be assessed, and we need to increase that face-to-face contact. But we are getting some positive feedback that a certain group of patients like the convenience have been able to speak to their GP on the telephone. Just picking up Councillor Atkins's point around equity, people who've got learning disabilities, who are frail, might have hearing problems. Certainly telephone consultations are not best suited for those, and we're doing a lot of work with practices in terms of a personalised approach to how they offer a range of appointments and healthcare professionals, and I think Sarah can perhaps pick up on some of that. So it's called May Highlights, but in terms of the numbers, the volume of numbers we're getting, we've seen this month 5% year-on-year growth in terms of the numbers of consultations that we're doing. There is some duplication in terms of people being seen face-to-face and on the phone, but it's around another 15,500 appointments per month, and that equates to 2 additional clinics, 2 surgeries that every practice in Stoke-on-Trent is having to put on to manage the volume of activity. I think the capacity is there, though. I think one of the big problems I'm sure your constituents are raising with you is telephone access, long waits on the phone. And certainly we obviously follow social media as well. We know where we've got some hotspots of certain practices. And this is an issue because even if we had enough telephone lines, answering those calls is extremely difficult. One 10,000 list practice pre-pandemic was seeing 3,000 calls a week. That equates to around 4,000 now. So if you scale that up across Staffordshire, you're talking another 100,000 phone calls per week that practices are dealing with. The volumes are eye-watering, in fact. If we can just go to the next slide, please. So these are some of the drivers, and again, this is what colleagues in other parts of the NHS have raised around delayed demand, about people not presenting early during lockdown. But I think there are some issues that are specific to general practice that's causing some problems in terms of access too. So during the pandemic, same-day appointments were readily available, and that's not the case now. So people don't want to wait for a few days for their appointment because we've almost got used to that same-day access. We've talked a bit about social distancing and the time it takes for the donning and doffing of PPE, which limits the number of consultations practices can give in any given day alongside the cleaning. I think there'll be an expectation as of the 19th of July that some of this will go back to normal in terms of the volumes that we can put through waiting rooms and the time it takes for PPE. I mean, if you look at the news this morning, it talks about, I think in terms of the announcements later today around masks not being compulsory, but you've probably heard the other side from the BMA suggesting this may not be the case in certain healthcare settings. So I think there'll be an expectation that things will be back to normal on the 19th, but perhaps the reality is some of these things will remain. 111, again, they are seeing huge calls, and I think we're in a difficult situation where people can't get through to 111 and then will try their practice. There are longer waits on the phone due to the vaccine queries. We're getting huge amounts of calls about the vaccine still. But I think there's two areas that perhaps just want to draw your attention to. Firstly, it's the range of healthcare professionals that we've got in general practice now. And certainly people talk a lot about wanting to see their GP. And actually, we've got a whole range of healthcare professionals that may be better suited to a patient's needs. And actually, we've got these over the last sort of 12, 18 months, we've recruited 225 new healthcare professionals into our practices. But what I don't think we've done is communicate that to the public. So they don't know that they could see a clinical pharmacist, and they don't want to because they want to see the GP. So that's one major issue. The other issue is perhaps something more deep set, and it's about the variability amongst practices, particularly in deprived and diverse communities. This was a problem pre-pandemic, so these practices were still had a level of inequality then, but I think it's more pronounced now. And actually, what we could be looking at is a situation where we're actually widening the healthcare gap because the access is even worse than it was before in these areas. If we move to the next slide, please. So during the pandemic, I'd said that we kept all of our practices open. These are some of the things that we did during that time. So we shored up our business continuity plans. I don't think general practices ever had such robust emergency planning. It gave us a real opportunity to look down to practice business continuity, but also at a network level and as a system level. And certainly that paid off during the pandemic. We supported the move to total triage as an organisation, and we continued to deliver extended access and extended hours through our primary care networks and hubs. In terms of the resilience piece, I think there's a level of fatigue now amongst practices, particularly with the vaccination programme. But we have been working with the People Hub, which is a workforce bank that practices have been able to access as part of their day-to-day running and also to support the vaccination programme. And we continue to encourage practices to use this resource so staff don't get burnt out. Just a final point. We've data in primary care is in the past, I think, has not been very forthcoming, but we've been working with practices for some time now, and we've got We're able to monitor across all of our practices the appointment system, so we know which areas are delivering more or less face-to-face appointments. We can monitor this on a weekly basis. We've got a lot more intelligence driving where we might have some problems. We've also got a dashboard that covers not just access, but other indicators where there might be quality issues, and we regularly monitor that with the team of our quality teams and clinicians to identify any practices that we might have particular concern with. Go to the next slide. As I said, I don't think we've promoted the different roles that we've recruited to over the last 12 months. The additional roles scheme was introduced in July 19, and we've appointed 225 whole-time equivalents. So these are things like first contact physios, social prescribers, mental health practitioners. So we've got a whole range of team health professionals that complement the practice team, but I think we need to do a lot of work around promoting these, what they do and how they will work differently. So next slide, please. We recognise as well, I think, particularly in the last 2 months, April in particular had extremely high levels of demand. That access has become a problem before the July 19 opening up day. And I think what this slide does in terms of the actions we're putting in place, I just want to get the point over, really, we're not being complacent. We have a weekly access summit with GPs and other members of the team that join that to make sure we're currently on top of the latest communications. We know those practices where we've got particular issues and we work with those. And we make sure that we're able to support practices during difficult times, because actually I know it's patients are very frustrated. They've been on the phone a number of times, they've waited a long time, and actually it's quite a difficult place to be from a practice team perspective, particularly receptionist staff. So we're constantly monitoring from both sides. What I shall do, Sarah, if I can hand over to you and present some of the plans that we've got in place now.
Sure, no problem. Thanks, Lynn. My name's Sarah Jeffrey. I'm Acting Deputy Director of Primary Care across the 6 CCGs in Staffordshire and Stoke-on-Trent. I mean, we've got in place quite a detailed action plan just so that we can monitor all the associated actions across the specific areas. It's by no means a finished product. It's a working document and it's an evolving plan. If you can move on to the next slide for me, please. So picking up on the key points around communications, there is a working group in place, which is separate to the meeting that Lynn just picked up on. It has quite a few patient representatives. They've been supporting us to develop and deliver the key actions that we've been putting in place. We're also reviewing the feedback from the desktop review that Health Watch have recently done. This is going to play quite an important factor in potentially some new actions that will come out of that. If you can move on to the next slide for me, please. So there's also a programme that NHS England developed called Time for Care, which targets practices who have challenges. Support team looks at their demand, their workforce, looks at the way their practice operates, its systems and processes, and then it looks to support and improve these. And while it isn't run by us directly as a system, what we've actively been doing is encouraging practices to participate, to support them with improving their overall access agenda. And to date, we've got around 14 practices that have asked to participate in that. So that's really good news. The next slide, please, for me. So we've also been developing an audit checklist to support an appreciative inquiry. And this is really to look at how practices communicate with patients so that they record patients' needs, particularly where they need any adjustments to usual practices, whether that be around disability or alternative methods of communication. This is really important in terms of the points that were raised earlier on as part of the conversations on restoration and recovery, particularly around inequalities and making sure that we're supporting that agenda. Next slide, please. The digital solutions have obviously played a crucial part of the development for access, and they're still continuing improving. We've increased our telephone lines for practices, but we've also been doing some work with practices to consider the productivity of their phone lines. So Lynn touched upon earlier that, you know, it's difficult to get through. Yes, while there's, there might not be necessarily the workforce to answer the phone, there's also a need for additional phone lines in general practice and linking that back to their capacity and that demand. So we're working with practices around that at the moment and doing an audit so that we can look at how we can best support them with that. We're also working with practices around their websites, making sure that they have relevant, easy to access, up-to-date information, and linking this back to making sure that that comms is targeted to the right people in the right way. And we're also improving use of and promoting the NHS app to patients that can use it or want to use it, and making sure that practices are allowing patients access to that. We're also making sure that we're checking record keeping and making sure it's in line with the appropriate guidance, particularly now with lots of video consultations, photographs, etc., making sure that practice is doing what they need to do in line with that appropriate guidance. If you can go on to the next slide for me, please. We're looking at levels of activity, and I think Lynn touched upon this earlier in terms of kind of that comparator and that benchmark, looking at their population sizes, making sure we haven't got any unwarranted variation. And we'll look to support practices where this occurs to understand and work with them to resolve these issues. We're engaging around patients' participation, that we're encouraging that engagement again. A lot of this did stop during the pandemic. It needs to be restarted in a way that supports the patient population coverage of each practice. If you move on to the next slide for me. We're also supporting reception admin staff with call handler training. As Lynn described it, it's been quite difficult that you know, people are frustrated. There has been some abuse of staff, but we're also supporting our practice managers with resilience training. We've done a reception survey to look at any additional needs that receptionists might have. Next slide, please. And a few things going on in regards to workload, including training around active signposted, some reinvigoration around this. There's always that kind of, the kind of thing that patients say around the reception, asking why are they asking what's wrong with them. It's so that they can best support them. So we're doing some work with our reception staff training around this, so they can ask these questions in the right way. We're also working with our local community pharmacies on a GP pharmacy referral scheme. And although the rise in appointments for general practice, this does need some further work and support. So we're looking to start this work soon. And then if you move on to I think this might be the last slide. We do need to ensure that we're continuing to measure the impact. We're monitoring the trends, looking at the data, but equally we need to check this with the patient feedback and soft intelligence that we get, triangulating the information back to ensure our communities are getting the best possible care. And obviously touched upon earlier was, you know, the patient stories, and those patient stories are really important. We're working really hard with our communications team to pick up on the kind of social media elements, making sure that we're triangulating all that information and feeding that back into our plan about what patients need. Thank you.
Thank you, Sarah. Thank you, Lynn. very comprehensive. Let me just make one comment, which is your slide deck is slightly different to the one we have in front of us. Not that much dissimilar, but it is slightly different. So could you just send Debs a copy of that? We will circulate that after the meeting around members and make sure it's available to people. One question that comes from that, and then I'll pass over to Charlotte Atkins just to make sure that we've picked up all her points. The level of increase year on year in April was 8%. In terms of people accessing primary care, and a drop to only a 5% increase in May. What do we think drove that? What do we think the long-term trend is going to be? Are you planning a 5% increase, or are you expecting another drop to 2 or 3%?
Thank you. If I just may answer this is my view. I think if you look at April's activity, it really went through the roof. I mean, if you think that on the 12th of April, we opened up after the second lockdown, you would expect that to be lower than it was. But it was, for me, I think it was a blip. I think the 12th of April came and the floodgates opened, and they opened in general practice. The noise I got from practices at the time was it was far worse in April than it is perhaps now. But I'd expect it to dip. I'd expect a 5% growth throughout the year now.
Thank you, most helpful. Charlotte.
Thank you, Chair. Just going back to the issue about face-to-face appointments at GP surgeries, my concern is actually about patient choice, both in terms of people being aware that they actually could insist on a face-to-face appointment, and so therefore I'm interested to know whether the CCGs are going to be talking to GPs about reintroducing face-to-face appointments, or whether, given that GPs basically are small businesses, whether they make their own decisions about how they run their service. And the other thing I'm concerned about is, we talk a lot about communications, but what I couldn't see within the tables you were providing is whether sufficient information is given to patients about switching. Because actually, if I'm not happy with my GP, I should be facilitated to going to another GP. And, we have some excellent GPs locally, but clearly the practices between GPs are very different. And therefore it might, if I had the information about another GP surgery and how it compared with mine, I might then be facilitated to make that switch. So what are you doing about ensuring that patients, one, realise they have a choice, and if that choice is not being provided by the GP, that they then have the information by which they can then switch to another GP? Thank you.
Thank you. If I perhaps take the question about face-to-face, and Sarah, perhaps if you could pick up around how you can switch practices. So in terms of your first point, I think where we're moving to is one from what patients need clinically to what they want. And I think that's really important distinction, isn't it? That actually some patients want a face-to-face appointment, but don't necessarily clinically need one. And that's the message we're starting to talk about by GPs. So clearly social distancing, in whatever form it remains, is going to remain a problem for practices. Some practices have got very small waiting rooms, which is obviously limits the number of people that can be in there. So it is going to be an ongoing issue, but it's different between every practice. I think if we got one of our GP colleagues on the call, what they would say is actually most GPs want to get back to seeing their patients, to be able to do an examination, to be able to do more of a holistic assessment of their patients, to be able to feel them and do everything that they've been trained to do as doctors. So I think the majority of our GPs now want to get back to delivering more face-to-face appointments, but they are constrained. The telephone consults work, they're popular, but I think the ratio is probably wrong at the moment in terms of the 50-50. I think we need to increase this to around 60-40 at the very least and go from there. It's about the right balance, isn't it?
Could I just quickly follow up on that? When you say that the telephone appointments are popular, have you done some sort of analysis of who they're popular with and who they're unpopular with?
Yeah. So this is the feedback that we're getting at, and that's one of the pieces of work we want to undertake, because the general practice has changed over the last 12 months compared to pre-pandemic in a way that was actually part of a a primary care strategy. But we've not done that engaging piece of work that goes alongside it. So what we want to do is a refresh of the model of care for general practice, and we'll do that with key stakeholders. So we'll make that assessment with patients, with other service providers, with our local medical committees, and we'll do that piece of work. But the soft intelligence that we've got so far does suggest that some people, and you're right, it's perhaps a certain cohort of people do like having the convenience of an appointment. So, you know, without wanting to make any generalisations, certain, you know, the younger working population, the feedback we get that it's quite popular. But we need to do that piece of work so we can understand that better. The other thing I would say is we monitor the activity levels very closely, and actually where we do have concerns around face-to-face appointments, it's usually in nurse appointments, because actually the nurses are generally seeing long-term conditions. They need to do those assessments and reviews, and we'd expect a higher rate of face-to-face in these groups. So we're monitoring all of this to allow us to have informed decisions with each individual practice.
Do you want to come back, Charlotte?
The second part of the question was going to be answered. Thank you.
Yeah, you're right. Patients do have a choice and can switch. I personally say that you know, we do have information around our quality of general practices in the form of a quality dashboard, which is available on our website. Our team are also linked in, as well as our PALS team, in supporting patients with access to GP practices that might be in their area that cover where they live. I do think, though, you have a point around supporting the access agenda. So I think there is more that we can actually do, and I happily build that into the access plan in terms of that communication around checking what our websites actually say and where we can direct patients.
Thank you.
So can I just follow up what Charlotte was saying? I think you indicated there's some further outputs in terms of what patients prefer, that research that you're doing. I think that'll be useful for us to see. And I noticed on the action plan that you're also planning on doing, gathering some information from general practice receptionists on perceptions and challenges and barriers. I think that again is something this committee might be interested just to see and maybe take a summary on, maybe in paper, well, electronic form, not paper because we don't cut down trees, but maybe just have it as a summary paper which we can look at and then decide whether it's something we want to explore further. Is that in line with everyone's thoughts here?
Can I come in with my comments before we get into that situation, Chairman?
Philip, do you want to carry on then?
It's great to have a choice of GPs, but I represent a rural area, and I think, as I've said at the last meeting, this is a health scrutiny committee, it's not an NHS scrutiny committee. And I think some of the modern ways of working, and I understand the idea to try and signpost patients towards other things such as phone call, phone consultation, or go to the pharmacy and try and find something rather than end up in a GP's waiting room. But there's one of the things that I've been banging on about for a number of years about infrastructure. And I'm pleased to see that Colin Wildman's in the room as well, because he can take this back to East Staffordshire Borough Council. They've built houses in various parts of the borough, and as a result of that, my residents were told, those who were attending surgeries in Uttoxeter, that they couldn't accommodate them anymore because there are about, I don't know, 1,800 houses being built and no increase in the GP surgery in Uttoxeter. So that's then put pressure on the Abbots Bromley and Roaster practices who were probably glad of having the additional patients, but then that leads to problems about access to GP surgeries in rural villages. So before we pat ourselves on the back, there are things that we as local councils should be thinking about.
Lynn, do you want to pick that up?
Yeah, certainly, thank you. I think there seems to be a huge amount of housing being built in around Staffordshire, particularly in certain hotspots like Uttoxeter, Cheadle, down in the south, particularly sort of the Birmingham, Oversville type areas, so Lichfield, at Burton, all seeing huge amounts of building going on around their practices, and not necessarily alongside the development of not necessarily new practices, but suitable practice facilities. We've just undertaken a utilisation study of all of our practices that's due to be presented to our primary care committee next month. And what that does is look at where we might have some difficulties in terms of the perhaps the levels of demand not matching the practice facilities. I will say I think we've been off the mark over the years in terms of working with the local authorities. I think as we move towards CCGs, the estates function was taken back by NHS England, and I think that probably was a part of the problem that we have now, that we've not been able to match our local capacity needs to the demand. What I will say is that we have been working with the local authority to develop practice sites, and that's had huge benefits, and it's something we'd want to continue to do. So we were lucky enough in Staffordshire to attract only 2 out of around 5 transformation capital funds, and we've got 2 sites that are just about, they're nearly built. One of them's in Burntwood and one of them's in Stoke-on-Trent, but we did that by working with the local authority. And I think we need to do more working with your planning teams to make sure that we can, where we have got opportunities to, ride on the back of some of the developments, that we can actually make most use of those and invest in healthcare facilities where appropriate. So I think it's something we need to do more of going forward.
Philip, do you want to come back?
Yeah, thanks, Chairman. Yeah, the County Council has got an integrated strategic plan, which I would hope the NHS have input into. Because the issue is that the builders and developers, while they're quite happy to sit on plots while house prices go up and they make bigger profits, but they should be contributing through to these facilities. I understand the NHS's traditional attitude is we'll have to go to government and get more money, but people are building houses, and it's the planning process that should have made sure that there are contributions at least to the health. There are contributions to education through a formula about how many children are likely to come out of a housing development, but we should be looking at contributions towards road, highway infrastructure, health and education from new housing developers, rather than seeing, and I say this as a landowner, land prices going up through the roof.
Thank you, Philip. I don't think anyone who works in district councils and borough councils would disagree. And in fairness, it's probably a planning matter. So, Lynn, I will ask you a question which comes off the back of it, but let me bring in Colin Wildman first, if I can.
Thank you, Chair. I will certainly take it back to ESBC, Philip, without a doubt. Actually, it's something that I've often raised concerns about as regarding doctor surgeries and so on. I speak to lots of residents, and maybe a question for the panel up at the top there. Branston Stretton in Burton, we have an issue where Stretton residents are having to go all the way to Branston to access doctor's surgeries. So when I ask you, when I hear you say, telephone, excuse me, telephone consultations are excellent, there is no replacement for face-to-face, and I would agree with Lady Councillor over there. There is no. I just feel when talking to residents that we do have a real issue with the phone consultations. I understand that it's a good thing regarding COVID, but I think the sooner we get to face-to-face consultations, the better. Just one last thing. My doctor's surgery has a pre-recording. You were talking about staff at doctor's surgeries having training. My doctor's surgery does have a pre-recording as to say that the receptionist may ask you, what your problem is. And I certainly have no problem with that, and I don't think many people do. It's just the fact that trying to get through on the telephone is very difficult, and that is a real issue and causes stress for many residents, I must say. Thank you.
Lynn, do you want to pick that up?
Yeah, just to say, I think the telephone issue, obviously, I've referred to. The process that was put in place during COVID was total triage, and actually, I think it worked. It's had its time and place, but actually, it's part of the problem. It's causing duplication. It's causing more telephone calls, and it's almost driving part of the problem itself in terms of it a solution that's certainly the opposite. So most practices now are moving away from total triage, and we're working with other practices to help them to put appropriate processes in. Like Sarah said, it's down to each individual's practice processes that they operate. So what we want to do is share best practice. You know, for example, if there are pre-recordings that we can actually share with other practices, we'll do that. But yes, I do agree. I think there's a place for telephone consultations, but it can't ever replace face-to-face appointments. Just in terms of your particular practice, you talked to, I think that's Trent Meadows, I think, and I do know in the area that there's a main road between Stretton and the main surgery site in Branston, and we're currently working with the practice around how we support access at both sites at the moment. So we are aware of the issue around that particular practice, Councillor.
Thank you. So just let me add my comments on planning, which is I would encourage everyone who is on the district or borough councils to make sure if you've got your local plan, there is a clear statement in terms of section 106 needing to go and support healthcare. And equally that comment also applies to neighbourhood plans. The number of neighbourhood plans I've seen which talk about development but don't talk about the actual physical infrastructure is unbelievable. Just go and pick up a few and you'll see that my comment is very valid. One for you, Lynn, on that though. Can we get a commitment from the CCG that you will respond to consultations where there is more than, say, 250 homes being proposed? Because that seems to me to be critical that you are engaged and involved in that sort of process. Because otherwise, how can you be putting pressure on the relevant local authority to get the Section 106? You need to make sure that there is appropriate and adequate healthcare provision.
Yes, I can absolutely sign up to that. One of our problems as a team has been that we were never set up to manage estates programmes. We've done it fairly well, but what we've done is appointed a planning officer. We're in the process of the recruitment for that planning officer who will lead on the Section 106 negotiations for us. We have had one successful application in Rugeley, so we're very grateful for that. What we're finding though, there may be different processes between councils. So we've had two neighbouring councils have differing outcomes of the same application. So it'd be helpful just to understand that. But certainly, I think absolutely we would want to work with you on ensuring we've got the right level of capacity and adequate buildings and facilities in primary care and take advantage of any funding opportunities that we have.
Thank you, Lynn. That's really helpful. So when you get that process, so we know how that works, could you just drop us a brief note on that? And I would ask district and borough colleagues here today to make sure that you take that back to your planning departments, and given we are member-led, we need to make sure that our officers actually do deliver on this to make sure this happens. Otherwise, it's a self-fulfilling prophecy. But a useful discussion, Philip, slightly outside of where we are, but useful. I'm going to go to Keith and then on to David. Keith.
Thank you, Chair. Yeah, my comment really is something that I think was probably in place even before the pandemic. I notice you've got the plan here to take things forward. Out of hours access, I think, is something that we haven't mentioned so far, but I do think that's quite critical. I had an issue myself recently where I could see that my daughter's knee wasn't injured, it just needed to be put up and everything else, but because it was reported and the doctor rang up and everything else, we had to spend 5 or 6 hours in A&E completely unnecessarily, taking up time, doing x-rays and everything else, because that's what we're advised to do by the general practice. So I just think that there's a bit of work to do with communications internally within the various services to try and minimise what is needed to be done. I'd just like to say that she's back at school fine already, but she's not going to do long jump again, but there you go. Anyway, so in terms of pent-up demand and what's going on at the moment, I do think that trying to increase potential access to services within the community, now that might be at GP practices, it might be at smaller community hospitals, it might even be at some community assets, I'm not sure. But certainly I think that it would be more convenient for the vast majority of the population of this county. It will certainly be greener in terms of the fact that you reduce the amount of time that you travel and the amount of energy you use up going to and from these services. And I do think in the long term it might be more resilient because it takes away the requirement, if we have another pandemic or other outbreaks, to have to go to the one place you probably don't want to go in the middle of a pandemic, which is straight to the place where all the ill people are, which is the hospitals. And I can never understand why you want to send all the people who are primarily ill that haven't got COVID to the place where the COVID actually exists in large numbers. I've never quite understood that. So I do think that there's some work that needs to be done. It's potentially away from the pandemic, the issues around GP practices and everything else. But I'm just saying that it would be good to have some idea, and I take the French model when I went skiing and everything else. They just scanned my knee, did a bit of radiotherapy. I was skiing in 2 days' time. Now over here, you'd probably be referred for 3 weeks before you even got seen to. I just think that there's some things here that we could do a lot better, and to bring in the community and the idea of training within the community and access to facilities and everything else. We're trying to get community services up and up. I know Jill's done a lot of work on this within Stone and other areas. And I just think that if we could get the training sorted out, we could get the assistance, we wouldn't have to pester doctors so much. I know pester's the wrong word, but that's what I felt like I was doing unnecessarily. And I just think that that's something that as a whole community we could work together on. And I'm quite excited with the idea of social prescribing and all these other things as well. That I think it's great, digital services, giving people the idea to be able to phone up, to be able to do a Zoom meeting or to do something else, not necessarily even taking up the doctor's time, but accessing the nurses as well. And I just think there's an awful lot that could be done. And in your plan at the moment, I don't see that variability. I don't see that going forward. And I'd love that to be included within the future of definitely GP practices, but more integrated within the whole way that services are being provided at the moment, and to take that heat off A&E, and again, don't send people who aren't ill to hospitals where illness is, if you see what I mean. Not just COVID, but flu, everything. I just think that if we can keep things away, keep things in a much more local community basis, I think that will help GP practices. It will certainly be better to spend 106 money on those. But anyway, I'll stop now.
Thank you, Keith.
I think
we got your point. Lynn?
I mean, absolutely. I think we're a bit back to front in terms of presenting an action plan around access and what is something around the wider model of care for primary care. So we've gone the wrong way, if you like, but I think access means different things to different people, as you've quite clearly articulated. What we really see this piece of work now around engaging with the public and our practices around what that future looks like, and what services we need to build around communities. But actually, while we are 146 practices in Stafford and Stoke-on-Trent, we've also established 26 primary care networks, which is a lot more about that place-based model of care, and it's a lot more holistic than just going to see your doctor. So we're at the beginning of that piece of work, but certainly as we progress this, I'm sure we'll be coming back to yourselves to have conversations around what it looks like for your constituents.
Can I just add one little comment about training? And I don't mean just training in terms of medical training, I mean training as in how you expect people to be able to interact with all these new changes, if in fact we can get some of those changes being accepted. And then it's the idea of how people then would access that could then take a lot of responsibility back to yourselves, because at the moment I feel that you're sort of being pushed down paths you don't necessarily want to necessarily go to, and you've got to have those emergency services and those critical services sort of separated slightly from what you'd normally do in terms of being healthy and everything else. So a bit of training around that, both in the public domain, but also for volunteers and all these other things. There's thousands of volunteers in the county now that I'm sure will be very happy with that. Thank you.
That's really helpful, thank you.
Just can I ask a supplementary on that? How effective do you think we are? How effective do you think you are, or your receptionists are in GPs, in getting the patient to the right point first off? So instead of someone who needs to be referred to maybe a physiotherapist, will the receptionist get that person to the physiotherapist first time, or has it got to go via the doctor? Are we elongating the patient's journey and the number of handoff points and all those other things? How effective is that journey?
I think it's variable amongst practices. Sarah, if you wouldn't mind, I'm just thinking some of the work you've done around the receptionist training, around the protocols that practices have put in place, because it has to be clinically led, doesn't it? So would you mind just describing some of that?
Yeah, certainly. There's a training program around reception training in regards to them doing that navigation. Originally was kind of care navigation, but that's now more of a specific role, and it's more about trying to get the patient to the right place the first time. That's very much so. We haven't done any work on actually evaluating it at the moment because of the pandemic. It's kind of, it's almost paused. So when I describe the action plan, that training has been reinvigorated. Those receptionists are going to have refreshed training in order to support them. But equally, there's no reason why we can't do some work around actually evaluating how that plays out in reality. Feedback from practices would say that the majority of the time the patient gets to the right place, but unless you've got the evidence, we don't know whether that is the case. Also goes back to how much the patients will share. And again, the points picked up around working with our communities around that training, making sure they're understanding what is available, where, and how they access it is a really important part of that.
Thank you, that's useful. The other point I just wanted to raise before I bring David in is if you're going to put more services into the community-based services, which I think everyone would welcome, are you doing an estates review at the same stage to make sure that your estate is suitable and capable of taking that? Because it would otherwise be left hand wants to do one thing and the right hand can't facilitate it.
No, absolutely, and we need to be taking advantage of the public assets that we have, and working closely with yourselves, with other public sector services, for example, the fire, to maximise the use of our estate. So we have a programme of work in primary care around the general practice estate, but this is linked into the system-wide estates programme that Paul Brown, our finance director, chairs, and it's got all organisations around the table, so we can make sure that we're working together in a way that we've probably not done before, actually. So in answer to your question, yes. We need to work on our public estate because that's what it is.
Thanks, Lynn. David.
Thank you, Chair. I could spend hours boring you to tears with the disasters that exist at my practice. Suffice to say, I injured my foot in March. In August, I shall be seeing the physiotherapist. I'm so looking forward to that. One of the healthcare professionals I've spoken to there, when I asked the question, where are all the GPs? She said, they only work 2 days a week. And then with a degree of bitterness, she said, they're all out vaccinating people at 20 quid a time. Grr. Your comments on that, please.
Yeah, that's helpful, thank you. So it's £12.58 a jab, actually, just to make it clear. But they do get jabbed twice, so there's a double payment there. But no, I'm not being facetious. We are obviously had a huge burden placed on general practice with the vaccination programme. So 70% of the vaccines have been delivered by our GPs within their primary care networks. And I think that's the distinction really in terms of practices. What we've wanted them to do is to ensure that they can maintain business as usual during the pandemic. And one of the ways of doing that is for them to work together and make effective use of estates, of the workforce that we have. I talked earlier about the Workforce Hub. We've actively encouraged practices to access the Workforce Hub so they're not taking patients away from the front line. in some areas it is an issue, and I would be interested to know which practice you're at, if there are any problems you want to have a conversation afterwards. But just to put some context to it, practices are able to get through a huge volume of vaccines in quite a short space of time. So although the numbers are eye-watering, in terms of how many clinics a practice might put on a week, for example, it may just be a one day. So I've got one primary care network that can see 2,800 patients through a clinic in a day. So it shouldn't, and these often the clinics are provided at weekends and evenings, particularly now, as most patients in the younger cohorts aren't readily available in the day. So there's a lot of activity, and our deliveries are mostly usually Friday into the weekends, and that's when the clinic capacity is put on. So it shouldn't have a huge impact on the daily delivery. I think early on in the programme, the priority was to save lives. And, you know, I know that there's a financial incentive or a payment for practices, but genuinely over the Christmas period, their main aim was to ensure we vaccinated the care homes, the over 80s, because the evidence suggests the more people you vaccinated, the more lives you save in that cohort. In care homes, for example, for every 20 vaccination, a life saved. So early on in the process, we actively supported our practices vaccinating as many people as they could in the shortest time possible. But the part of the enhanced service that they have to sign up to clearly states this has to be over and above their business as usual. They have to ensure that practices remain open and there's a level of access, and we would closely monitor that. So if you do have any concerns, we're happy to pick that up on a specific practice basis.
Yeah, thank you for that. But the reality of life with my practice is you cannot get to see a doctor. It's impossible.
And perhaps, Councillor, if you wouldn't mind letting me know afterwards, we'll happily look into that practice. Is this soft intelligence that we need to follow up on things?
Thank you, Richard.
Thank you, Chairman. One of my concerns, it probably follows on from what Charlotte actually had said in terms of equality. I'm deeply concerned, certainly the surgery that I go to, where you have the recorded message and that you are in a queue, and you are told you're 10th in the queue, and a few minutes later you're 10th in the queue, and 5 minutes later you're 10th in the queue. And actually, the phone call I had, it was 40 minutes as I progressed to being answered. That is a cost to any individual on the landline or whatever. And I am concerned, and I represent some of my community are not necessarily affluent, and I'm deeply concerned that they are being disadvantaged in the process. I'm pleased to hear training and development, but I think, as Keith alluded to, there's something missing there in what we then see as visibles. There is a perception that we probably share right throughout Staffordshire that our GP services are not offering the service that we would probably like to see. We appreciate the pandemic, but when anecdotally a very good friend of mine who works for the NHS at a very large hospital, and her comment was, but the NHS is being let down by GP surgeries. Now that's a bit of an indictment that there's an accusation that's going on there, and I think that's something whether you could probably iron it out. The other thing I wanted to just pick up on, you mentioned Rugeley, and of course I didn't catch the context of you then saying Rugeley. I wonder if you could just elaborate on that, because if it was something to do with obviously a number of GP surgeries, certainly the village that I live in, you know, we have residents that actually use Councillor Jessel's Yoxall practice, and it's a question of really what you know, I go into Lichfield, what is the situation in terms of numbers, because there's a lot of house build that's going on, and we're waiting for 2,000 houses to start get going in, and that provision really has to be on the money, because that perception that we don't have places for GPs, etc., needs to be removed and answered.
Okay, thank you. I think general practice is having a great deal of bad press at the moment. It's almost as if they've gone from hero to zero with the vaccination programme, and then now they're faced with the difficulties of getting back to a normal. I think I've obviously talked about the calls during the presentation, but I think the difficulty is literally overnight increasing Staffordshire's telephone contacts by 100,000 calls per week is at the crux of the problem. General practice cannot recruit or put enough telephone lines in place to be able to manage that volume of calls, and I think there's a bit of engagement we need to do with the public as well, because actually we need a level of patience, and I know it's really frustrating for people, but this isn't going to change overnight. So it's sort of how we manage the expectations, but equally how we make sure that people receive the care and the treatment that they need in a timely manner. And I don't think that's something we're going to resolve today, but it's certainly an issue, and that's certainly part of the programme of work we were going through. And actually, we know which practices are particularly poor in terms of their capacity. Obviously, won't name and shame them now, but we do know who they are, and we are working closely with those that delivering a service that is below what anybody would expect. So when we mention Rugeley, I'll bring Sarah in, because this is your patch really, isn't it, Rugeley? The comment I made was around we attracted some Section 106 funding, which was why I mentioned Rugeley. But did you want to comment on the capacity in Rugeley, Sarah?
Yeah, I think it was the power station review in terms of the planning there for housing. I think that's what Lynn was referring to in terms of the success story. If I recall correctly, that was about extending potentially one of the surgeries, possibly with a better reputation, I may add. Just picking up on Lynn's point about telephone lines, there are a couple of surgeries in Rugeley that we're actually working with at the moment on their issues around the queue. We've put in across Stoke 120, I think it's 127 additional lines. They are interim lines, but they're free for the practices to use. And obviously, as part of that action plan that I talked about earlier, we're doing a review with all practices on access to their telephone lines, because they need to ensure that they're kind of meeting their demand. Some surgeries are moving to cloud-based solutions, which are much more efficient. You don't have a limited number of lines. So, if you're making calls going outside of the practice, it doesn't affect the lines coming in. So, there is a lot of work to do still. Like Lynn said, there's been that additional demand. But in terms of Rugeley, yeah, we are aware of a couple of practices, and we're working really closely with them at the moment.
I don't want to have a very localised discussion, so I will allow you to come back, but let's not talk about planning, because we've already talked about it, and let's not talk about a very localised practice.
It answered what I suspected to be the answer, and even at planning level, there was a dissatisfaction that the developer in this instance actually was willing to provide a building and a surgery, and obviously the result was on extending existing facilities, and that is what is not very productive, because it's a lot of extension to facilities that are struggling to actually deal with the population. So I don't want to extend on it, but it's exactly the answer I thought I was going to get, and it's not a happy answer. Thank you.
Can I just come back very briefly on phone lines? It does strike me that if I was running a call centre, and I used to run a customer service team many years ago, we'd arrange callbacks so that people could leave their details and you could automate a callback. We'd look at call minimisation. What could we do to get rid of the call in the first place? Electronic booking of GP appointments would seem to me to be something there. I think there are technical solutions for some of these things that we need to pick up, and maybe we need to start with a blank piece of paper and look at it the other way round, rather than the inherited architecture that we've got. But let me leave those comments there. I don't think they need response to, given time. And Angela.
Thank you very much, Chairman. And I'm really pleased to hear that what Philip mentioned about housing and the population. I mean, what my question really is, has anybody looked back over the last 10 years as to how the population's grown in Staffordshire, as to how we relate to how many doctors we've got to fulfil our obligations to the public? You know, so, you know, if that survey's been done, that would be great to have a look back and just see how it's grown. My question is about the ICE. Please clarify for me whether this is working correctly. My understanding is there's a system, a computer system between the hospital consultants to the doctor's surgeries called ICE. My understanding is the information I'm picking up, that it's failing, that the information from the consultants of the hospital is not getting through to the doctor's surgery. Can you clarify that that is working okay, or is there a problem with the system? Thank you.
We're wandering quite a long way with planning and with ICE off the topic we're meant to be on here. I will allow this question, but then I'll bring this issue to a close if people haven't got relevant questions to the topic we're meant to be discussing.
Just in terms of the growth, I'll ask Sarah to pick up on the ICE issue. It's not something I'm aware of. But just in terms of the growth, we've had a primary care strategy that's actually reduced the number of practices. That's not necessarily around space, but we're growing our practice footprint. So our ambition is to have an optimal practice list size of around 10,000 registered patients per list. So for me, that gives greater resilience in the practice in terms of the facilities. Some of our small practices in the past have been single-handed practices in rather poor facilities, and we've looked to merge partnerships and grow our practice footprint that way, rather than increase the number of practices that we've got, if that makes sense. But we do collect data around the number of patients registered with any given GP at an individual level. So we know on average how many patients each GP has on its list compared to their doctor size, and there is an optimal amount of that, and that's something we'll refresh as part of the primary care strategy going forward. Sarah, are you aware of any problems with the pathology system? Have you heard that?
I haven't had anything reported in terms of issues, so we could just raise that with our head of digital.
Yeah.
Maybe Anne could share some of the details that she's got, which makes the question more focused for just checking. Is that? Yeah, okay, brilliant. So we'll share those details, and if you could come back to Anne in writing, I'd be grateful, please. Are there any further questions on GP access? So,
just a comment, Chairman.
Yep.
While I've been sitting here listening, I thought I'd have a look at my NHS app, which has got my medical history. It tells me what interventions I've had over the last, back to 2008, and I can also make a GP appointment. I think we're moving forward in a different way, and people have got to, I think there's a little bit of education on part of everybody. Instead of picking up the phone and having a very long message from my GP who's speaking about 25 minutes to the second, and press 1 to this and 2 for that. But there's another way of doing it. So I tell everybody, get the NHS app. You can book an appointment, but please keep it. If you're going to cancel it, cancel it.
Thank you, Philip. So can I just pick up one other element from my perspective? Because I think Anne's question, which really probably is trying to answer the question, is the current issue a long-term problem or a short-term one? I.e., is it COVID-related or is it just systemic? But it strikes me that you've got a range of dashboards that you're developing, which would be interesting just to take outside of this meeting and have a look at some of those and what information that might give us, both as a holistic system approach as well as a sort of a regional practice by practice approach. I don't want all the detail, but I'd just be interested in being able to deep dive, because it strikes me that potentially there would be an opportunity to look at those practices that are underdiagnosing disease or overdiagnosing disease, depending on what you're collecting within that data. And some of that could be quite interesting in terms of supporting appropriate diagnosis levels across various areas.
We've got a programme of work, that's a really good question, as this is about health outcomes, isn't it, and inequality, and the vaccine programme has opened my eyes to the inequalities we have in Staffordshire and Stoke-on-Trent. We've got a programme of work that is primary care variation and inequality that we've just set up. It's been led by Dr. Shami Noor, and a member of my team who are leading on that piece of work. And what it really does is look where we have got poorer outcomes and why. It looks at whether it's a deprivation issue, it's an access issue, or potentially it's whether it's an issue within an individual GP. So there's a whole programme of work that we're developing at the moment, and education and resource packages that go with that in future I'm happy to discuss with you. We've also not been very visible in terms of our primary care data, and we are pushing this out into the system now. So as part of the system dashboards, we're also reporting primary care consultations, face-to-face, and other outcomes-based data. So we want to be more open and transparent about that.
Really useful and a welcome being part of that debate. Thank you.
Okay.
On that basis, I've got no further indications. We would like just to thank you and Sarah for your input to the GPS access. A really key issue for many, many councillors across many regions. Understand some of the issues, and thank you for what you've said today. Let's move on to item 6 on the agenda, which is a COVID update. So I think that's you, Lynn, again. And Sarah, you're welcome to stay, but if you want to go, please feel free.
Thank you, everyone. Quickly run through where we are with the COVID vaccination programme. Hopefully I can run through this quite quickly. So if we're on the tail end of the first phase of the programme now, so we are heading towards the July the 19th D-Day in terms of offering 85% of appointments to all adults and 2/3 being double dosed. I'm pleased to say that in Staffordshire and Stoke-on-Trent, we've always tried to be ahead of the game, and currently 83% of our adult population has been vaccinated, and we've met the 2/3 target for those being fully dosed. So that's really good news, and I've no doubt by the 19th we'll have at least 85%, if not higher, uptake levels for the vaccine in those first doses. So if we can start the presentation, Tanisha. Here's some figures. There's lots of big numbers in there in terms of 65 million people being vaccinated nationally. It's about 1.4 million for ourselves. That's number of doses, 780,000 people having the first dose and 600,000 seconds. I've run through these numbers before, so I'll let you look at these in your own leisure, really, but just pull out some of the highlights of it for me. The most important thing that we did was vaccinate our care homes and our care home staff very quickly. 100% of our homes have been vaccinated, 98% of our care home residents, and I think it's about 87% of our care home staff. We did this in partnership with the local authority, and we wouldn't have been able to have such high uptake rates without working as part of that system-wide approach, but particularly local authority and district council colleagues. So very grateful of that, and it's no doubt saved lives, and due to those high uptake rates. Again, in those first cohorts, we're over 90% for cohorts 1 to 9. And that's been largely around general practice having the reach. So access is different to different people, isn't it? We have our large scale centres that people can conveniently book an appointment with, or the community pharmacies when it suits them. But in some kinds of terms, it's around having the reach of general practice, the registered list, and that respect between the patient and the doctor in terms of feeling safe to have the vaccine. So very high uptake rates. The other area I'm particularly proud of is our learning disability uptake rates. 89% of people with a learning disability have had their first dose. Again, one size doesn't fit all. We've had to adopt different approaches. We've had to work with different organisations, and it takes time. But it's a very important group of people who've received a very vulnerable during COVID, and we've managed to achieve some of the highest rates of learning disabilities uptake rates. It talks about there being one of the highest rates of the vaccine delivery regionally and nationally, and that's something that we're very proud of, and all parts of the system have worked very well together to deliver that. And it's about our local communities, isn't it, and our population being safe. We were one of the first sites to be approved to use Moderna, so there's 16 sites nationally that use Moderna. So MPFT, who run our vaccine centres, are one of the few groups of centres that operate 3 vaccines. The standard is 2, but our sites run AstraZeneca, Pfizer and Moderna, and again that shows sort of the capability we've got in our providers. Next slide, please. So I've gone ahead here, haven't I, in terms of the care homes plan, but very much thanks to those local targeted efforts between health and social care. I won't run through those numbers again, but just to say as a reminder, for every 20 vaccines given, we expected to save a life. So over Christmas, absolutely crucial that our practices got in there so early. And I think the impact on our secondary care was quite relatively early in around the February as well, when they started seeing a reduction in admissions from care homes because patients had been vaccinated. So the next slide. So it's very clear that the COVID is going to be with us for the longer term, and also the vaccination programme is going to be with us longer term. So we've always seen it in 4 phases. The first phase, those cohorts 1 to 9, the at-risk groups, and phase 2, where we are in terms of the rest of the adult population. So everybody between 18 and 40 years old, and that's required a different approach. So some of the learning is convenience, access, walk-in clinics are probably some of the learning in terms of going forward, how we vaccinate populations again. One of the things I will say in terms of one and two, we've always operated a principle about never leaving anyone behind. So we have an evergreen model that we continue to go back through all of the cohorts to make sure we've got as many people vaccinated as possible, not least populations that might have some inequality, deprived areas, high ethnically diverse populations, and we understand where we've got lower rates, and that's just not acceptable to us as a programme. We've been doing a lot of work around making sure that we do things differently to make it as easy as possible to be vaccinated, and I'll talk a bit some of the work we've done with the fire service that's been absolutely crucial to that. Where we're looking ahead now, we're looking ahead towards building a vaccination strategy that's very much tied up with flu, and clearly that's around phase 4. We need to increase our uptake rates for all of our vaccination and immunisations programmes. But in between 2 and 4, there's phase 3, and this is what we're all looking to the autumn to now. What we're expecting, some guidance came out last week, is that we'll be delivering a booster programme for adults over the age of 50. We'll be doing it in risk order again, so cohorts 1 to 5 will be the first people vaccinated because of any potential risk going into the winter. What we will also be doing is vaccinating for flu at the same time. We're expecting to double dose people at the same time, so almost 1 jab in each arm of flu and COVID to maximise those uptake rates, but also to make it as efficient as possible. Clinical trials are underway now, so we don't know which vaccine will be the booster. Clearly, the new variants coming through will determine that. But for example, we're modelling this in different ways in terms of our capacity requirements, and potentially we're looking at having, if you had AstraZeneca for your first dose, your second dose will be a Pfizer dose. So we need to model all that through to understand how we manage our capacity in the supply chain to make sure that's very effective. As you remember me talking before, the different vaccines have different cold chain requirements and storage requirements, so it's quite a complex logistical issue to manage, but we'll get there. So we're doing that. The other scenario that's playing out is around children and young adults. So we are planning to vaccinate school-age children between the ages of 12 and 17 with flu and COVID, and that'll be a 2-dose COVID full vaccination for children. Clearly, there needs to be a lot of communication nationally around how that will look to parents and the approvals process, but we'll work through that over the next month. So we're not sitting on our laurels. We've got a lot to do in a short space of time. We've got to get through the assurance process and contracts ready to start the phase 3 vaccination booster programme in September the 2nd. So a lot to do, but I'm confident as a system we'll work very closely together to be able to manage that and deliver in the same way as we have done with phase 1s and 2. So the next slide, please. We also work very closely with the local authority in terms of responding to outbreaks. So the national response around moving second doses forward from 12 to 8 weeks, we've delivered on that. Everybody has been offered now in 1 to 9 a vaccine at 8 weeks. It was a bit of a difficult situation because it meant in a 3-week period we had to deliver another 145,000 vaccines. hence the pressure on practices. It has added to that, because that wasn't something they planned for. It was something they were asked to do by central government to make sure people were kept as safe as possible. We've brought forward our second doses for the under 40s, and we've worked very closely with public health teams, Richard Harling, around ensuring that we appropriately manage vaccinations. And we were commended by the Cabinet Office team and some of the regional public health teams about how well that's worked in terms of our collective resources to manage outbreaks, particularly in places like Leek, where we brought forward all vaccinations. I've just noticed in there, Tamworth's a bit like New York, so good it named it twice, but Tamworth in there twice for no particular reason, but there's some of the areas that we've worked on. We're putting on lots of different options around walk-in clinics, particularly at the universities. They've been very popular. We were very proactive in terms of vaccinating our universities before the cohort numbers were released, because we had a captive audience and we got a great response from younger people, which we didn't necessarily expect. We were getting 1,000 students through our university pop-ups in a day. We had to go and get some more vaccine from Stafford University. We can go to the next slide, please. So I talked a bit about some of the inequalities that exist, and these are stark. And early on in the programme, we could see that we'd got some inequalities that just weren't acceptable. So we had certain ethnic groups. If the white British uptake rate was 78%, for our Bangladeshi communities it was 47%, and that meant we had whole populations at risk of COVID, and that was across certain areas in Staffordshire and Stoke-on-Trent where we've got ethnically diverse populations. But it wasn't necessarily just about deprivation. There were other groups like people with learning disabilities that we had to target in a different way, and also a huge number of migrant workers working on fruit farms who just weren't coming forward, and indeed they weren't registered on practice lists, so they're almost an invisible population. The fire service approached us about how could they help, and we've been working very closely with them. That's Rich Williams, one of the fire officers who's been leading on this with their fire service. They provide the staff, the vehicles, and we go out to different populations with the vaccination team who do the jabs. What we found is the response towards the fire service in terms of being that trusted brand has been different compared to perhaps our health service. And I'll give you an example that Rich was talking about on the fruit farms. Imagine if you were to go over to Eastern Europe in a country you didn't understand and somebody was trying to stick a needle with some Russian medication in there. How would you respond to that? And actually, it's the face of the fire service is allowed to get and see patients and get to populations we just wouldn't be able to see from health alone. So it's been great. We've been able to do different pop-up clinics at different locations, and we'll continue to work with the fire service going forward, because what their at-risk groups in terms of fire are also our at-risk groups. So there's a perfect partnership for the future there, I think. Next slide. We had a big weekend last weekend, probably unfortunately known Grab a Jab weekend, and we put lots of pop-up capacity over and above our core clinics across a number of locations. The limiting factor for us was the availability of vaccine, an appropriate vaccine that we can port. We're sitting on a lot of AstraZeneca. Sorry, my dog. We're sitting on a lot of AstraZeneca vaccine because actually, clearly the guidance changed around the under 40s and using that vaccine, but also we can get more out of the vials, so the vials kept coming. But there's some of the walk-in centres. Next slide. I've talked a bit about this in terms of the second dose, particularly with the new variant, the Delta variant. The evidence has shown that it's less effective on one dose than maybe the previous variants. Hence the need to pull forward all of the second doses as soon as possible. So once people are fully dosed, the same levels of resistance of around 80, 85, up to 90%. So very effective vaccine, but you need 2 doses. And actually, we're seeing people come back for their second doses as well. Got good compliance with the second doses and very few delays. So that's really good. Next slide, please. So we've talked a bit about access. We've had probably more sites in Staffordshire than elsewhere, and we focus on local sites. So 3 big vaccination centres. They won't cut it in terms of what we need to do. We've got 23 PCN sites, primary care network sites, and a further 11 community pharmacy sites. But beyond that, we do know now that we can take vaccine out to practices as well. So where you might be concerned we've got some gaps in that picture, general practices is also vaccinating to have that local access too. Next slide. Yeah, we've talked about high uptake, but there is some hesitancy that we've found. As you probably know, people who've seen me present before, there's a bit of a triumvirate between Neil Carr, representing the community, and the SRO, myself from primary care, and also Paddy Hannigan, Dr. Paddy Hannigan, who's led from the clinical perspective. So, you know, we've done a lot around going on local radio, and Paddy's been at the front of this, particularly in terms of doing webinars for people who may be put off, pregnant women. We had a lot of issues in care homes, and originally about people concerned about fertility. And we were very concerned that younger groups may be more hesitant, and we found actually that they are coming forward. It's almost the opposite. So this is a long-term programme. We need to be continuing to work with our councillor colleagues, our leaders in the community, to make sure that we can dispel some of the myths that have happened over the last 12 months. Next slide, please. This is, when I say this is almost old news, it's not at all, but there was some concern perhaps about 3 months ago around the risk of blood clots for the under 40s, and certainly the guidance has changed in terms of the vaccines that are delivered to the under 40s now to mitigate that risk. It's extremely rare. This is, I won't even try to say cerebral vein sinus thrombosis or even some of the other phases in there, but what it is it's how the blood clots in the brain in terms of the platelets, and it's extremely rare. It's not comparable to, say, stroke or DVT. Prior to the national guidance changing, we screened all of our population through our practice lists to try and identify anybody who might be at risk. But clearly the new guidance has come into play, and very much the message is that the risk of not vaccinating outweighs the risk of being vaccinated in terms of contracting COVID. So the other area that we've actually introduced is around Pfizer or Moderna for anybody pregnant who may be over the age of 40. And certainly if people have got completely risk averse, we'd rather just get people vaccinated. Next slide, please. So we're obviously taking a look back now at what's been done really well, and certainly the system working and the partnership working we've done has been amazing. We wouldn't be where we are today without everybody in our system: health, social care, local authority, other public sector bodies, police and fire, working with us towards this shared objective to vaccinate. It's been fantastic. We've had a distributed leadership model through our programme where we've set up a programme team, and I've had a member of Stoke City Council leading on the estates across the whole of Staffordshire and Stoke-on-Trent, and that's been really great to see people owning this programme. I've talked a bit around the inequalities, and I won't run through all of those items, but I think this is something that we need to take away around the difference in uptake rates, but also outcomes and access in certain communities. This is the only 100% population coverage programme I've done, but I'm already thinking now in terms of how I develop primary care, what inequality means for access and outcomes, and I've talked about the programme, but certainly it's something we need to take with us going forward. Next slide, please. I think we all know we can't let our guard down. I think we'll be waiting with bated breath today when our Prime Minister announced the next steps. I think there's lots of unanswered questions around PPE and social distancing, particularly in health. But clearly we can't let our guard down, and even if you do have your vaccination, there is still a risk of contracting COVID, be it minimal. It's more around the severity of disease. Just to give you an example, there was an outbreak recently with 37 positive cases. Only 2 had been vaccinated out of those 37, and in terms of their health, they were well. It was more that they'd just been positive, so it didn't affect them adversely. But just give you an idea, you can still catch COVID. Next slide, please. Here you go. I think it's time for some questions if we've got time, Chair.
Thank you, Lynn. Let's take some questions.
Thank you,
Chair. It's very nice to have 2 mentions of Tamworth as well, so keep pushing that, please. I was pleased to hear how effective the vaccination programme has been so far, and how we've got the plan for the boosters. Just one thing that came up at our last scrutiny meeting in Tamworth is, could we have some clarification on how the targeted vaccination programme for homeless people has been operated across Staffordshire? Were they encouraged to walk-ins, or were appointments made? If you could give me some clarification on that, please.
Yeah, sure. We actually went earlier than the national guidance to vaccinate homeless people, and the reason for that was it was pre-March, and we knew a lot of the 225 known homeless people that we have were actually in a sheltered accommodation at that point, as part of the winter plan that the local authorities have put in place. So we vaccinated them in situ before they kind of dispersed, and we can see our second dose rates are quite a bit lower, and one of the issues for us is we can't find these people now. So my recommendation when we do the booster programme is that we do them in winter when people are in the first and second doses, when they are in, well, the first doses when they are in the sheltered accommodation. So it's been very much a targeted approach. Working with the community trust, we've gone out to vaccinate. We've got some practices that have got homeless populations registered with them. In those circumstances, we've got the practices themselves vaccinated. But you have to bring the vaccine to people in these circumstances. And we've had tea and cakes available at the time of the clinics to encourage people to come forward. So I think there's quite a bit of learning. But we've had good uptake rates for our first doses, but not so much our second, which is a concern for us.
Thank you, Lynn. I don't see any further questions, so I'll make 4 comments. One is, I believe there's a vaccine webinar this Thursday at 6 p.m, which is an update really post from the Prime Minister's announcements that are coming through, which will just give a further update in terms of what's left. Second of all, I think this is a brilliant expose that you've done of the vaccine programme from start to finish, and I would encourage colleagues to share details of this that can be watched back for members who are interested to actually chart where we're up to. So thank you for that. I think Tamworth will be pleased to be compared to New York, albeit they're much better. And finally, we are going to look at the winter flu and COVID vaccination programme in September. But otherwise, thanks for that input, Lynn, much appreciated. Thanks for your input as ever. Let me move on to item 7. Before I hand over to the Cabinet Member for Health and Care, can I just make 2 comments? First comment is that we are being asked to comment on the proposals to send this piece of work to consultation. So we don't have to beat all the detail through this one, but I think that we will see this paper again in a different format once it's been to consultation. So I think it's worth us understanding the background to it rather than the forward process. Let me hand over to the Cabinet Member.
Yes, thank you very much, Chairman. And I believe Jan Cartman-Frost is online, as is Richard, in case there are any detailed questions. Actually, what this committee is being asked to do is to endorse the commencement of an options appraisal, not a consultation as such. And it's for all respite, or they're called replacement care services. I do apologise, I tend to call them respite care services for people with learning disabilities. As we all know, this is a vital service both for users and for people who care for people with learning disabilities. And it is essential that we continue with these services, but this is an opportunity to do an options appraisal so we can see what is the best model for the future. The process will engage with users, carers, service providers, other stakeholders, as well as, obviously, we welcome the input from this Overview and Scrutiny Committee. The report sets out the current provision, together with its strengths and weaknesses, and issues raised by the current COVID-19 situation. It's obviously limited the capacity of the existing service, and this report does set that out. it also identifies the difficulties that have been encountered with the premises at Douglas Road. Because of the layout of this road, in effect the first floor hasn't been used, and again it has severely restricted the usage of those premises. The report also details the contracted out services. Some of them are contracted out, some of them are provided in-house, and outlines the numbers of residents, the costs for residential and home-based care services. The recent CQC guidance has also added to the need to review the care service at Douglas Road. The option of potentially combining it with another service wouldn't be supported. CQC guidance is that residential homes should cater for no more than 6 people at any one time. So this provides a real opportunity to review and redesign these services to provide the flexible and supportive service we wish to see in the future, and that is also affordable in the future. So, as you quite rightly say, Chairman, this is the forerunner of that options appraisal report, which obviously will come to this committee at a later date. I'm happy to answer any questions, as indeed would Richard and Jan. Thank you.
Thank you. Charlotte Atkins.
Yeah, just wanted to know what we've learnt during the COVID pandemic in terms of services to people with learning disabilities. I see that home-based services, not surprisingly, increased during that period. So what are the lessons learned for the future? And secondly, when we're looking at options for the future, what provision is going to be made for people with learning disabilities who are becoming elderly and therefore have no, in some cases will have no relatives who can actually take on some element of their care and support?
Chairman, if I could ask Jan or Richard to answer those detailed questions. Thank you.
Chairman.
Oh, sorry.
Chairman, I'll have a go and bring Jan in. So I think the lesson from COVID is that institutions are probably an undesirable place for people to spend their time unless there really is no alternative. I think both for people in permanent residential and nursing care and in terms of the availability of replacement care services, we've seen all sorts of problems with using care homes. And I think for the future, what we would aspire to do is to support as many people as possible to live at home and independently. Coming on to the second question about when there are no relatives to care for people, there obviously comes a time for some people, unfortunately, where it is no longer possible to stay at home because it is simply impossible to provide that care either from in-reach services or for relatives. And then, unfortunately, we do have to consider options like care homes. But I think the lesson for the future is that we would want that to be absolutely a last resort. Thank you.
Yeah, just in terms of care homes, I mean, are you thinking that there would be specialist care homes, or are you suggesting that they would be integrated into the mainstream care home system?
Difficult to say. I think as far as possible, we would want to, where people require care homes, just use the existing care home system and possibly develop some specialist beds rather than create some specialist care homes where it's not clear what the demand might be and where you are sort of vulnerable to very small numbers of people and demand changing quite a lot. So it might be specialist beds rather than dedicated homes. But I think there's quite a lot of analysis to do in the wake of the COVID pandemic to really understand what the future demand looks like. I think the intention here is to look at replacement care for people with learning disabilities, but the intention is to look at the wider care home market, and I believe that's scheduled for consideration through this committee sometime prior to September. Thank you.
Thank you, Richard.
Thank you. From one Atkins to the other then.
Yeah, to the other one. Thanks, Chairman. Just looking through the community impact assessment, and there is a spelling mistake in the word align, I think on page 58 to 59. I think one of the things that does come through is there has been some regular meaningful engagement and communication undertaken, but I think that in essence creates anxiety for both the people who are going to be directly affected and those that are going to be indirectly affected. So one of my pleas would be that, yes, consult, talk, but eventually you need to make a decision. And in many of the changes that have been instigated in the past, when you get to the new world, it's actually a lot better than the old world, because we don't want to go to the old world of shutting people away and forgetting them. They have a role in society if they unfortunately have got some learning disability, and we need to move quickly and help them and their parents and their carers, etc. So my plea is don't get bogged down in consultation for ages and ages.
I obviously used the wrong word earlier, Philip, in terms of consultation, because it's an options appraisal, which the Cabinet member did pick up. Let me pass over to Julia, though.
Yes, that's a very well made point. And the report does say that a report will be coming to Cabinet in the third quarter, but I take the very well point, absolutely.
Thank you. I'm looking around the room. Keith Flunder.
Just a quick one. I don't know whether Alzheimer's and people suffering from Alzheimer's and all that within the care home system as well, will they be included within this and within the community? I have a carers cafe that actually looks after quite a lot of people with these conditions and everything else. Now, whether they're disabled or not, I don't know. Whether they'll be involved in it, I don't know. But is it just specifically for the care home facilities that we have at the moment, the specialised care home facilities, this analysis?
Richard will probably correct me, but this is for people with learning disabilities. It is a different group of patients that you're talking of. Thank you.
Yes, that's correct, Chair. The scope of this is people with learning disabilities, although they may be relatively young or older. The replacement care for older people and those with Alzheimer's is out of scope of this report.
Thank you. So I'm just going to add one comment or a question really. On page 49, there's a very good table of figures which indicates that there is a variability of cost, significant variability of cost between Woodlands Road and Silver Birch and Douglas Road, and that equally capacity changes cost as well. So will the report that comes back look at the financial viability of providers? Because the real danger is you go down one route because it looks like the right route to go down, and the long-term financial viability changes something and leaves us with less provision rather than more.
Yes, Chairman, I did say, obviously, whatever service provision has to be affordable in the future. I think with Douglas Road, I did raise the fact that its capacity has been significantly reduced. And of course, it is a service that we provide. So even if it's only half used, we carry the full overheads, and that's why the costs are disproportionately high.
Thank you. I think we were asked to endorse the recommendation of the Cabinet member to do an options appraisal. Do we endorse that? Brilliant, thank you. With that, I suggest that we move on to item number 8 of the agenda, which is District and Borough Health Scrutiny Activity. There is a range noted here. Does anyone want to provide updates in addition to what's already in the papers? I'll take that as a resounding no then. So on that basis, given the hour, I'm just going to move very alacriously on to item number 9, which is the first time members have seen the proposed work plan, and we're obviously in the middle of that work plan because we're on the 5th of July. The comment that was made about the financial viability of the care market, or the general care market overall, is coming up in January, care home services, which I think probably gives us some time to see what the impact from COVID is. There is one other change that I do want to bring committee's attention to, in addition to the work plan which is in front of you, which relates to Wally's Quarry. And I'm sure there aren't many people in this chamber who aren't aware of Wally's Quarry, if only because the issues have been long-standing and ongoing with the quarry in Silverdale, Newcastle area. But the health impacts have been felt across a much wider area, across principally Newcastle, but equally across Stoke-on-Trent, across North Stafford, Stafford Boroughs area. And it is our intention to bring that issue in terms of the health impacts that are coming from Wally's Quarry to this committee for discussion. It isn't anything more than the health impacts, and there will be significant and sufficient papers for us to discuss. We haven't yet agreed on a date, but it's likely to be in the next 2 or 3 weeks, so that it is timely and relevant. And the reason we haven't agreed a date is that we need to make sure we have the right representation in the room. There is no point in us having a scrutiny session without the right people, which would obviously include Dr. Richard Harling and his public health team, would include the Environment Agency, the district and county council representatives, to make sure that we can talk about the health impacts that are coming from Wally's Quarry. Does anyone have, thank you, that's good. Does anyone have any comments they would like to make on either that comment or the work programme itself? Just let me ask Ian Wilkes, who is our representative from the district at Newcastle, are you happy with that as a proposal?
Yeah, very happy with that. The discussion we had prior, if that goes through, more than happy. We will get it sorted and hopefully have you all in Newcastle.
Thank you. Yeah, the suggestion is that we will host that meeting, well, we won't host that meeting. Newcastle Borough Council will host that meeting in Newcastle for us, which would allow us an opportunity en route to go and see the landfill site. But equally, I know the Vice Chair and myself and Councillor Wilkes will go up separately. So if you don't want to do it before and you want to take a more detailed walk through the issues, then you're more than welcome to join us. We'll give you both dates. Phil Hewitt.
Yeah, only a second, Chair. Can I confirm that Councillor Johnny McMahon will be invited to that meeting? We have experience in Cannock of the same sort of issues, as well as his public health portfolio, or as well as his public health experience. He'll also bring an experience from the challenges we had in Cannock Chase.
Good suggestion, and we will be inviting Dr. McMahon to join us, yes. No dissent on the work programme, so that's good. As soon as we get the date for Wally's Quarry, we will let you know, and I hope as many members will be able to facilitate the additional meeting. Otherwise, I see no reason not to close the meeting, and thank you for your attendance today. Thank you.